स्ट्रीमिंग हो रहा है यहाँ से। हेलो। देखो ना, एक बार मैं चेक करता हूँ। हुआ स्टार्ट। ओके ओके ओके, हो गया। हो हो गया हो गया हो गया। थैंक यू। ठीक है, थैंक यू। ठीक है। स्टार्ट। Hello everyone, very warm welcome to all of you guys. Myself, Dr. Vaibhav Jain. And please do let me know if I'm clearly audible and visible. There was a technical glitch. I think it is sorted now. Hello, hello. Tell me guys if you can see me and hear me well. Audio visual is fine. Do let me know in the chat section so that we can proceed for the class. I'm waiting for your confirmation. Hello, hello. Hi Nidhi. Life is beautiful. I'm good. All good, all good. Welcome, guys. Welcome to the session. I know it's been a long time since we have not taken any classes, but today we are going to do a very nice session of anesthesia, guys. I know it's been last 25 days for your examination, and I really want you guys to be very interactive with me because I have incorporated all the important PYQs here itself. Everything that is required for your anesthesia will be covered in this particular session. Okay, so feel free about that. Don't worry about the NMC notice, guys. At this point of time, there is a much more important thing for you, that is the exam. Please try to focus on the exam because these things will be running here and there. Every now and then, NMC is always putting some notices. So feel free about that. You will get used to it. Okay, what you need to do, you need to get the best out of it. Whatever things are happening, you just need to get the best out of it. Okay, at this point of time, you guys are here. I really want you guys to be very interactive with me because till the end of this session, you guys will be understanding all anesthesia. I would be teaching you anesthesia. Along with that, I will be let you solve all the questions because some people already know how to study but they don't know how to utilize that information. Okay, so we will be utilizing all the theoretical information along with the questions. Okay, myself Dr. Vaibhav Jain, those of you who don't know me, and we will be starting anesthesia, and these are my Instagram and Telegram in case if you want to connect with me for any kind of updates and questions. Okay, so without any further delay, I think we should get started now. Okay, first thing, what are the topics that are coming in the anesthesia, guys? What are the topics? First thing, topic number one, that is your introduction. Okay, so we will be starting with the introduction. What are the things from introduction? They will ask you some question based on the history part. Okay, after that we will be seeing what are the different types of anesthesias we are having general anesthesia, regional anesthesia. Okay, then we are gonna do the pre-anesthetic checkup. What is that? Sir, a patient is coming to you for some kind of surgery. What are the different things you will be checking up for that patient will be coming under this pre-anesthetic checkup. Okay, then we are going to understand, the patient will come back to us, then we're going to understand what is that intubation, how we are going to do the intubation. Apart from that, what are different monitors that are present in your OT, right? After that, we are going to study about the anesthesia machine, all the questions from that. Okay, then we are going to do the circuits, what are open circuit, closed circuits, semi-closed circuits. Then we are going to see some anesthetic agent, that is the drug part. Okay, what are different drugs that you will be utilizing in your anesthesiology. And then some questions are coming from oxygen therapy, and we will be understanding different kind of fluids like when to use RNS, RL, DNS, what are those, okay, and some miscellaneous topic that has been asked in your examination and important for your exam, right? So we will be discussing one by one all these things. Be with me till the end of the session. High power guys, 25 days are left for the examination. I want you guys to be very interactive, okay? So the first slide, let's talk about some slides. First of all, I'm going to teach you some theory and then I will be asking you some questions, okay? So who is this gentleman in front of you? This is your WTG Morton. This gentleman is your WTG Morton. And why it is important? So this is also known as the father of anesthesiology. He is considered as the father of anesthesiology, okay? He discovered the anesthesia, okay, and the term anesthesia was given by one scientist, that is Oliver Wendell Holmes, okay. 3-4 scientists you have to remember. Just remember the name of those scientists, okay. So Oliver Wendell Holmes is the scientist who has given the term anesthesia, okay. Anesthesia term was given by Oliver Wendell Holmes, okay. What was the date? When do we celebrate the World Anesthesia Day? Please try to answer. World Anesthesia Day is celebrated on 16th of October 1846, okay. 16th of October, and this was the day when they discovered anesthesia, that is your 16th of October 1846, okay. Who is this gentleman from PSM? Also you already know him, that is your John Snow. He was a practicing anesthesiologist back then, okay. He has done some surgeries for like Queen Victoria. So John Snow is also known as father of epidemiology, okay. He is also considered as the father of epidemiology, okay. Very good, Nandini. Next, who is this gentleman? This is your Edmund Gaskin Boyle. Edmund Gaskin Boyle. And he has given, just written in his name, he has given the Boyle's machine or Boyle's apparatus. Boyle's machine. He has given the Boyle's machine. Okay, one more scientist that you need to remember is your August Bayer. August Bayer has given the Bayer's block. I will be telling you what is Bayer's block. Different kind of anesthesia. You will be understanding everything. If you have done anesthesia, good. If you have not done, be with me. I will be teaching you everything. Okay. So these are the 5-6 scientists that you need to remember for now. Okay. First thing, who is the father of anesthesia? Wherever you are, try to speak. Okay, the father of anesthesia, WTG Morton. The term anesthesia was given by Sir Oliver Wendell Holmes, World Anesthesia Day, that is your 16th of October. John Snow, father of epidemiology. Edmund Gaskin Boyle has given the Boyle's machine. Apart from that, August Bayer has given the Bayer's block. Okay, next thing is your, what are the different types of anesthesias that we are having? What are the different types of anesthesia? Look here guys, we are having general anesthesia, we are having regional anesthesia, and some part of local anesthesia. Okay, general anesthesia means what? Look here, the complete body is getting anesthetized, right? Complete body is getting anesthetized. Okay, regional, we are having 3 things. Regional, we are having spinal, we are having epidural, we are having peripheral. Okay, spinal will be spinal and epidural. Remember, they are given below the, they are given on the back side, that is on the central, that is on the spine, right? And they will be utilized how? We will be telling you. Spinal for short term block, epidural for long term. Okay, epidural we are using for a long term and spinal we are using for short term. Okay, and this one is your peripheral block. Okay, apart from that, we are having local anesthesia. Local anesthesia we are using for a particular part of the body, right? So let's revise how we are going to do this. Okay, yes, this one will be helpful for NEET because I have incorporated INISET, FMGE and NEET PG, all the questions that has been asked in your examination. Okay, so general anesthesia is further divided. How we can achieve general anesthesia? We can use 2 types of drugs. We can use inhalational drugs. Okay, inhalational drugs. We can use IV agents. Okay, 2 types of drug we can use for general anesthesia. Okay, second one, for regional, just remember 2 things. Regional, particular region will be blocked. How we can achieve that? Either I can block it in the center part, that is your central neuraxial blockade. Okay, central neuraxial blockade. Second one is your peripheral neuraxial blockade. Okay, peripheral neuraxial blockade. Okay, so in center, what will come? Center, you will be finding your spinal anesthesia. In center, you will be finding spinal anesthesia. Apart from that, you will be finding epidural anesthesia. Epidural anesthesia. Apart from that, we are having caudal anesthesia. So whatever is given in the center, blocking in the center, that is central neuraxial blockade. In peripheral neuraxial blockade, we are having sciatic block, we are having like brachial plexus, you already know, that is brachial block. Okay, we can also give femoral block. Okay, so that would be your peripheral neuraxial blockade. Okay, in local anesthesia, we can use two things. Again, we can use infiltration, and we can give the drug topically. Okay, so we are having two things. One is infiltration, second one is your topical. Okay, one is infiltration, second one is your topical. Okay, so till now we have understood what are the different types of anesthesias we are having. We are having general, we are having regional, we are having local. General I can achieve by two methods, inhalational and IV. Regional I can achieve by two methods. One is central neuraxial blockade, second one is your peripheral neuraxial blockade. Did you understand? Next thing is your local anesthesia. I can give infiltration. That means drug is infiltrated around the area. For example, I need to do some kind of dental surgery. I need to do I need to extract some teeth. What I can do, I can put drugs all around. That is your infiltration anesthesia. Okay. Next one is your topical. I can put eutectic mixture of local anesthetics, that is amla, or I can use some kind of cream, that is topical anesthesia. Okay, you understood? Okay, so these are the basics types of anesthesia that we need to understand. Okay, one by one. Now what is happening? Try to understand all these things in the form of a story. A patient is coming to you, a patient is coming to you for some kind of a surgery. Okay, now you cannot do directly the surgery. Okay, what you need to do, first of all, you need to understand whether the patient is fit fine for the surgery. Okay, we are having elective surgery, we are having emergency surgeries. Okay, so I am talking about elective surgery. Now what is happening? A patient is coming to you, for example, he is having cholecystitis. Okay, and now we need to perform cholecystectomy, right? So I cannot directly operate the patient. What I will do, for example, I'm a surgeon. What I will do, I will send the patient to anesthesiologist. Okay, what he will be doing, he will be doing pre-anesthetic checkup. What is that, sir? Pre-anesthetic checkup matlab kya hota hai? What he will be looking inside the patient. Okay, for example, any patient is coming to you. Okay, any patient is coming to you, what will happen? You will be taking history to the patient. Okay, I will be taking all the questions, you can ask. Okay, in the last I will be taking all the questions. Okay, so what will happen when a patient is coming to you? We will be looking for the history. Any case we will be asking about the name, age and sex of the person. Why they are important, sir? Name will be telling about the religion of the patient. Okay, so we can identify the eating habits of the patient, whether the patient is a vegetarian or a non-vegetarian. Okay, age, because of age, some diseases are more common in older age groups. Okay, sex, some diseases are more common in female as compared to male. Okay, that is why history is important. In history, we are taking drug allergy history, we are taking medication history, what are the drugs he is consuming. We will also talk about some surgical history and anesthesia exposure history. So that are the history that the person will take. Second thing we will be doing is your general physical examination. In general physical examination, we will be looking for pulse, whether the patient is having BP, whether the patient is having cyanosis or some kind of pallor. Okay, so we will try to assess the patient whether he is fit and fine for the surgery. Okay, we will be doing systemic examinations, like we will be checking for cardiovascular system, we can check for respiratory system. Okay, we can check for CNS, GIT. Okay, why we are checking those systems? To understand whether the patient is able to excrete the drug that I would be giving. For example, his kidney is not working fine, is there any possibility if I am giving a drug, if his liver is not working, that drug will remain inside his body and that will cause more damage, right? So I will be checking for systemic examinations, and lastly we will be doing some kind of investigations like CBC, electrolytes, urea, creatinine will tell us about the kidney situation. Okay, we will be checking for all the electrolytes and all. Okay, next thing is your airway evaluation. That is the most important step, guys. Okay, most important step as far as anesthesia is concerned. This is the most important steps. Okay, so till now what we have done, the patient is coming to us, patient is need to have some surgery, we are sending patient to the anesthesia department. In the department, first thing that they will do is pre-anesthetic evaluation. This is the form of pre-anesthetic checkup. Okay, they will be asking for all these things. Then what will happen? The patient will be given some clearance, and after that only the surgery will happen, right? Now try to solve this question. How is the pre-operative evaluation of the oral cavity conducted in adult to facilitate endotracheal intubation? Okay, so what does this question wants to know, and you have to answer it. Okay, how to pre-operative evaluation of the oral cavity, where we are evaluating, what we are evaluating, we are evaluating the oral cavity. Here I told you airway evaluation, I told you about the airway evaluation. So how we are going to assess the oral cavity and why it is important? Very good, Dr. Rubik, Nandini, Muskan, very nice. Okay, Rohit, very nice. So that is the Mallampati score. You know that is Mallampati score is for the assessment of the size of the tongue. Okay, why? What is Conmack-Lihan grading? What is ASA grading? What is AHA? Just try to rule out the option. Okay, because in exam, it is your exam where you will be having no negative marking. But try to develop the habit. So when you are preparing for your NEET PG or final set examination, you know what happens, you will be already you will be knowing how to solve the question, right? So you need to eliminate the option. AHA grading is American Society of Heart, so that would be for cardiology. Okay, so AH is not concerned here. What is ASA grading? ASA grading is American Society of Anesthesiologists grading. Okay, what is Conmack-Lihan grading? It is the visual opening of the vocal cord. Okay, it is a visual opening of the vocal cord via laryngoscope. Okay, so that cannot be the answer. The answer here will be Mallampati score. Okay, try to understand what are those things. Okay, one by one we will try to open all the option and we will try to see, because so many questions have been asked from this particular topic, so we will try to open it, right? First of all, that is your ASA grading. What is that, sir? ASA grading, what is this? ASA grading, what we are going to see in the ASA grading, look here, this is your American Society of, this is ASA means what? American Society of Anesthesiologists grading. This is American Society of Anesthesiologists. And what are the things we will be assessing here? We will be assessing the physical status of the patient. Okay, physical status of the patient, whether the patient is fit or fine for the surgery. Everything we are talking in respect to surgery. Okay, anesthesia and surgery are working together, right? So we are discussing about that. So we have divided this ASA grading into 6 classes, that is 1 to 6. Okay, 1 to 6. And if we are adding E, that means that is for the emergency. Okay, if we are talking about 1, 2, 3, 4, 5, 6, that is for the elective surgery. And if I am talking about 1E, 2E, 3E, 4E, so that is for the emergency surgeries. What are the things that you need to remember, because question has been asked from this particular thing? Okay, so look here guys, ASA1 will be normal healthy patient. He might be having some kind of biochemical disorders or some kind of psychiatric disease, but this patient should be considered as ASA1. Okay, second is your ASA2. ASA2 will be mild systemic disease with no significant impact on daily activities. For example, the patient is having mild diabetes or controlled hypertension, so that would be considered under ASA2. What is ASA3? Sir, here the patient will be having severe systemic disease that is limiting the activity of the patient. For example, patient is having COPD, he cannot run far, right? Patient is having angina, that is basically the chest pain, right? ASA4 is for the patient is having a disease which is constant threat to life. Okay, for example, patient is having congestive heart failure, patient is having unstable angina, okay, renal failure, acute MI, respiratory failure. Okay, so all these things will be considered under ASA4. And ASA5 will be moribund patients. Okay, that means these patients, if they are not treated within last 24 hours, within next 24 hours, what will happen? The patient will die. Okay, and ASA6 will be brain dead patients. Okay, for organ harvesting we are utilizing ASA6. Sir, why it is important? For example, a patient is coming to you for cholecystectomy, right? Now you will be sending the particular patient for pre-anesthetic checkup. And now after pre-anesthetic checkup, what the anesthesiologist will write, we will write for example ASA1. Now our surgeon will be relaxed, okay, because he is having normal systemic diseases, okay, maybe he is having, maybe he is not having. But if the anesthesiologist will write ASA5, that means we have to be very careful while doing the surgery because it is a high risk patient, okay. So that is why it is important ASA grading, okay. Question that has been asked in our NEET PG and FMGE examination, they have given this disease. For example, the patient is having ruptured aneurysm, he will be considered under which category? So you need to remember it like that only, okay. So repeat with me, revise with me. ASA1 will be normal healthy patient, ASA2 mild systemic disease, ASA3 severe systemic diseases, ASA4 constant threat to life, ASA5 will be moribund patients, 24 hours we have to treat, and ASA6 will be organ harvesting. That is what is you have to remember as far as this ASA grading is concerned, okay. Next thing is your airway, okay. Let's talk about airway. Second most important question that has been asked in your examination is from the airway, and that is from the Mallam Patti grading, okay. That is from the Mallam Patti grading. So what we need to look here, we are having 4 classes of Mallam Patti grading, that is class 1, 2, 3 and 4. So what are the structures that are visible? That is the what are the structures that are visible? We will be looking for that. Mallam Patti grading is for the assessment of, it is for the assessment of oral cavity. It is for the assessment of oral cavity with respect to, sorry, it is the assessment of the tongue with respect to oral cavity. It is the assessment of, it is the assessment of size of tongue with respect to oral cavity, okay. So it will be telling us about the size of the tongue. If someone is having a big tongue, what will happen? Glottic opening will not be visible and he will be having difficult intubation, okay. So look here one by one. Yes, we have to remember the mnemonic. We are having a mnemonic, that is push. What is that push? First of all, let's see what are the structures that are visible here. We can see soft palate, we can see hard palate also, okay. We can see focal pillars, we can see everything is visible, uvula is visible, right? Now what will happen in class 2? Look here, pillars are not visible. In class 3 only the base of the uvula is visible along with the soft palate, and in class 4 only hard palate is visible, okay. So how we can remember? We can remember it with the help of a mnemonic, that is push, okay. So class 1 will be everything visible. Try to remember. Look here guys, class 1 will be everything visible, okay. Class 2, what will happen in the class 2? Pillars are not visible, so just try to cut the P, okay. Just cut the P from the push. So pillars are not visible, okay. Class 3, just remember U and S together, okay. In class 3, base of uvula is visible along with the soft palate. Two things will be visible, base of uvula along with soft palate. That is your class 3, okay. And lastly class 4, that only and only hard palate will be visible, okay. So just remember the mnemonic, because this question has been asked twice or thrice in the examinations. I have put it right. So class 1 will be everything visible. Repeat with me, class 1 everything visible. Class 2, what will not be visible? That is your pillars will not be visible. There will be no visibility of the pillars. So just remove the P. Class 3, just remember U and S together. That means the base of uvula will be visible along with the soft palate, okay. At class 4 will be only and only hard palate will be visible, okay. Only and only hard palate will be visible. So just remember the mnemonic push and your question will be done, okay. Very, very important question. They have asked this question multiple times, okay. Last one is your Cormack-Lehan grading. Cormack-Lehan grading system is the laryngoscopic view. It is the laryngoscopic view of glottic opening. It is the laryngoscopic view of glottic opening. That means when we are putting the laryngoscope inside the mouth of the patient, and then what we are seeing, what kind of vocal cords. These are your vocal cord. You must have studied in ANT also. These are your vocal cords. Okay, arytenoids, vocal cords, epiglottis, everything is visible here, right? When you are when your vocal cords are opened, we can see the opening. That means class, that is grade 1, that is your grade 2. In grade 3 and grade 4 there is no opening visible, and they are considered as difficult intubation. They are considered as difficult intubation. Just remember the name, that is your Cormack-Lehan grading. That is the laryngoscopic view of glottic opening. That is your class 3 and class 4. Okay, all right guys, here class 3 and class 4 in Malampatti also are considered as difficult intubation. Okay, so what we are seeing, basically what is happening, the patient is coming to anesthesia department. Now we are writing this is Malampatti 1, so that means we can easily intubate the patient. If it is Malampatti 4, they will be requiring some kind of specialization, right? They need to have some kind of anesthesiologist along with them for the intubation purpose, right? Cormack-Lehan grading, if that is the laryngoscopic view, that is also considered as the for the difficult intubation. Okay, so these are the grading system that we need to remember. Now please try to solve this question. When assessing a patient before anesthesia, the oral cavity should be examined. The image provided below displays the examined cavity. It illustrates what? Okay, this was the question that has been asked in your examination. And what is this, guys? Please try to answer. Look here, what we have remembered, we have remembered the mnemonic push. How to solve this question? If this question will come in your examination, what you guys will mark? Okay, so you have to remember the mnemonic push. P means what? Grade 1 will be everything visible, so we cannot see everything here. Okay, so this one cannot be the answer. We cannot see everything here. We cannot see everything here, so this one cannot be the answer. Very good, Pradeep. Very good, Mihir. Okay, Nandini, very good. So answer will be C. Why C, guys? Look here, why C? Class 2 will be what? Class 2 will be pillars will not be visible. Okay, but here pillars are not visible, but along with the pillars, base of uvula is only visible. Look here, guys, only base of uvula is visible along with the soft palate. Along with the soft palate, right? So this one can be answer number 3. Okay, this can be your Malampatti class 3. Okay, hard palate, that is your class 4. Okay, so this is your the base of uvula is visible along with the soft palate. So answer will be, this is your category 3, right? This is your class 3. Very nice, very nice. Okay, try to identify this one. Then identify the Malampatti class of this patient. Okay, now look here, what is visible here in this class? What is visible in this question? Please try to answer. Here only hard palate is visible. Only hard palate is visible. That means this is your class 4. Just remember, push again. Okay, class 1 everything visible, class 2 pillars not visible, class 3 base of uvula and soft palate will be visible, and class 4 will be only and only hard palate visible. So here the answer will be not 4, the answer will be C. Yeah, that is class 4. Okay, that is class 4. Very nice, very nice. Okay, now please try to answer this question. What is the appropriate pre-operative fasting recommendation? This was the question they have asked multiple times. Please try to answer this question, guys. What is the appropriate pre-operative fasting recommendations? Okay, just try to look here. First of all, we will understand how these things are happening. Then we will try to answer. Okay, so what is NPO orders? What is the meaning of NPO order, and what is that NPO? NPO means nil per oral order. That is your nil per oral order. Okay, that simply means before surgery, what the patient will eat, what patient can eat. Okay, so for example, normal life story, when you are going for a cholecystectomy, okay, now you are sent it to the anesthesiologist. Now anesthesiologist is looking at all the parameters of your body, and now what you are asking them, sir, when I'm coming for the surgery, what can I eat before surgery? I just want to have some, for example, the patient is thinking he might not survive, he just want to have some biryani or something like that. Okay, so he will be asking the doctor, right? he will be asking the doctor, and what the doctor will suggest, that is your nil per oral order, okay, NPO order. For adult patient can have full fatty meals, that is 8 hours before that. For example, he wants to have biryani, he can have biryani in the night and surgery in the morning, right? Next thing, for semi solid and semi solid food like dalia, khichdi, all those things, you can have those things 6 hours before the surgery. And clear fluid like water, you can have water like 2 hours before the surgery, okay? So we are having for the adults 8 hours for full fatty meals, 6 hours for semi solid food, and 2 hours for clear fluid, okay? Next thing, for pediatric, a little bit difference is there, that is your 8 hours for fatty meals, that is same, okay? We can use formula milk or semi solid for 6 hours. Again, 4 hours for breast milk. Breast milk will be 4 hours, and lastly clear fluid will be 2 hours. Sir, clear fluid and breast milks are approximately similar. Why we cannot give? Because breast milk will go to your GIT, it will be making some kind of a curdy thing when it will mix with the your acid, okay? So it will be making casein, protein will be broken down. It for example, those patients who are having like vomiting, those kids, they will be having some kind of a discharge, right? So that is your breast milk. So we need to give breast milk 4 hours before the surgery, okay? We cannot give beyond that, okay? So please try to answer the question now. The question is, what is the appropriate pre-operative fasting recommendation? Now look here, for adults or for infants we want to answer, okay? So we can give liquid in adults. The answer will be very good, Karishma. That would be your 2 hours for liquid in adults, okay? That is your 2 hours for liquid in adults, okay? Answer will be B. Okay. Now, what is the meaning of pre-anesthetic order? What is the meaning of pre-anesthetic order? That means now I have told you about the what are the things that you can eat. Now I will be telling you about the pre-anesthetic order. What are the drugs you can take before surgery? Okay. What are the drugs you can take before surgery? Okay. So we are having certain things we need to remember. Some questions has been asked from this particular table. Okay. This is the table you just need to see before examination. Okay. So I have made such more tables in the last. You just need to look at those pointers and one liners we have included, and just go to the exam, your paper will be done, okay? Anesthesia, feel free about it, okay? So we are having smoking. Those patients who are smoking, for elective surgery, if they are coming to me, I would be telling that we will be having surgery after 3 months. So I will be telling the patient to quit the smoking, okay? I will be telling the patient to quit the smoking, okay, 8 weeks before. Second thing, hormone replacement therapy, that is basically estrogen and progesterone. We can also block herbal medication because we don't know what is in that, okay? So we need to stop them also 6 to 8 weeks prior to surgery, okay? Tricyclic, just remember T for 3, okay? So that should be stopped 3 weeks prior to surgery, right? Ticlopidine 13 14, you can remember like that, okay? So that should be stopped 13 to 14. Ticlopidine 13 to 14, okay? Clopidogrel 5 to 7 days prior to surgery. Warfarin 4 days prior to surgery. Lithium we need to stop 48, 24 to 48 is the best option, okay? Heparin we need to stop 12 to 24 hours before surgery, and unfractionated heparin we can give 6 hours before the surgery, okay? These are important, but the more important are in the right, that is your oral hypoglycemic agents. These are your metformin and other drugs, hypoglycemic drugs, okay? Chlorpropamide, all those drugs that you are taking, sulfonylureas, we need to omit the last dose. Why? Because the patient is not eating anything, right? So we do not need any kind of hypoglycemic agents, right? Okay, if the surgery is going for such a long period of time, we can use insulin. We can shift the patient to insulin, okay? We can shift the patient to insulin, okay? Antihypertensive drugs, if the patient is on antihypertensive drug, we need to continue those drugs to maintain the BP of the patient. Apart from that, there are some exceptions, that is your ACE inhibitor and your ARB, that is angiotensin receptor blocker. These are your sartans and your prils. We need to stop those drugs, okay? We need to stop all your ACE inhibitors and your ARBs, okay? Aspirin we can continue low dose aspirin, that is your baby aspirin, okay? So we can continue baby aspirin. Okay, apart from that, what about thyroid medication? We need to continue thyroid medication. Okay, we need to continue the thyroid medication. These are the important ones that you should be remembering. I will be sharing the PDF. You can look in that. Okay, so these are the important points we need to remember. Okay, please try to answer this question. Glycopyrrolate is used as a pre-anesthetic agent for what? What is the purpose? Yes, that is omitted. Yes, we need to stop that, right? Okay, glycopyrrolate is used as a pre-anesthetic agent for reducing the secretions, guys. We are using it for the reducing the secretion so that the patient cannot aspirate. Okay, glycopyrrolate is an anticholinergic drug. Okay, so we need to understand what are the pre-operative medications that we need to remember here. Okay, so now try to recall our story. What is happening? A patient is coming to us. A patient is coming to us for cholecystectomy again. Okay, we are sending this patient from surgery department to anesthesia department. In anesthesia department, we are having pre-anesthetic checkup. In pre-anesthetic checkup, they are taking all the history, all the systemic examination, investigations. Okay, they are giving two orders. First one is your nil per oral order. Second one is your second order, that is your about the drugs. Okay, they will be telling us about the drugs, that is your. Okay, after that, what will happen? They will be giving some kind of pre-operative medications when the patient will be coming. When the patient will be coming for surgery, let's say they have given your PAC orders, that is pre-anesthetic order. Now what will happen? The patient will come for surgery. The patient will come for surgery. Now the patient must be anxious. Okay, after, for example, we have already told the patients to stop all those things. Now the patient must be anxious. Okay, so what we need to do? We need to give some pre-operative medications, right? What are those pre-operative medications that we have to remember? Look here, guys. First one is your anxiolytics. What is this anxiolytics? What are the drugs that we are utilizing? These are your basically benzodiazepines. These are basically your benzodiazepines. What are those? Like for example, we can use midazolam. We can also use diazepam. So basically these are the anxiolytics. They will be decreasing the uh, anxiety in the patient. Okay, we can also use alprazolam and all. Okay, we need to give antiemetic drugs. What are those antiemetic drugs? That is your 5-HT3 blocker. 5-HT3 blocker, that is your ondem. That is your ondem. Apart from that, we are having metoclopramide. We can also use, because metoclopramide is a prokinetic drug. What will happen when we are using metoclopramide? It will be increasing the movement in the body, and what will happen? Your GIT will get cleared, right? So we can also use metoclopramide. Okay, apart from that, we can use antacids. We can use proton pump inhibitors. Okay, proton pump inhibitors will be helping in decreasing the secretions. Okay, so it will be decreasing the, yes, it will be decreasing the acid. So what is that? We can use omeprazole. Okay, pantoprazole, lansoprazole, whatever prazole you want to use. Apart from that, that is the important, that is your anti-xylococcus, that is your glycopyrrolate. What is the function, sir? It will be decreasing the secretions. Okay, it is anticholinergic drug, so it will be decreasing the secretions, and because of that, what will happen? It will prevent the aspiration. Okay, so we can use glycopyrrolate to decrease the secretions. Okay, we also need to give some kind of antibiotics. What kind of antibiotics we are using? We are using broad spectrum antibiotics. Broad spectrum antibiotics, and that is your, for example, cephalosporin, we are using ceftriaxone. Generally, we are using cephalosporin. IV, we are using ceftriaxone. And the question that they will ask you, when do we need to administer this drug? Okay, the antibiotic we will be giving 1 hour prior to incision. Reason being, we are using multiple drugs, so it will not counteract with other drug. That is why we are giving this particular drug 1 hour prior to surgery, 1 hour prior to incision, right? What is the, now try to answer the question, what is the preferred drug for pre-operative antibiotic prophylaxis in a patient who is about to undergo cardiac surgery? Anxiolytics, no, we don't need intra-op. The patient will be unconscious itself. He will not be having any kind of anxiety. Okay, pre-op, when the patient is coming to OT, what will happen before all those things? He must be anxious. For example, you are having some kind of surgery, you will be anxious, right? To decrease those anxiety, we can use that. Okay, we are using many counter drugs also. Okay, so what is the preferred drug for pre-operative antibiotic prophylaxis in a patient who is about to undergo cardiac surgery? Try to answer, guys. Yes, I have told you about the cephalosporins. We will be using broad spectrum antibiotic, and here the answer will be cefazolin. Cefazolin is a cephalosporin. Okay, penicillin will be very narrow spectrum. It will not work very extensively. Okay, second one is your erythromycin, that is a macrolide, and also azithromycin is a macrolide, right? So we will try to give cephalosporin, that is your cefazolin. Okay, so answer here will be cefazolin, and this was the question they have asked you. Okay, now what is happening? The patient has already come into OT. We have given certain orders to the patient. Now the patient is hungry. He is coming to the OT, and before surgery, what we need to do? We need to intubate the patient. We need to get the access to the patient. Okay, so how we are intubating the patient, and what are the different things that are required for intubation? Okay, so what is the device that is used for intubation? That is known as laryngoscope. That is known as laryngoscope. The device that is used for intubation, that is known as laryngoscope. Okay, second thing, what are the different airway devices that we are having? Okay, so till now we are having two types, basically three types of airway devices. We will be discussing about, let's say, one by one. Okay, so basically what is happening, suppose this is your glottis, this is your glottic opening. So whatever device that are working above glottic opening are known as supraglottic airway device. Okay, whatever is going below that are known as infraglottic airway device. Okay, and apart from that, there are some other devices that are your airway adjuncts. These are known as airway adjuncts. Okay, are you guys understanding? So let's see one by one how these things are working and how we are going to introduce all those things. Okay, in supraglottic airway devices, very good. Here we will be having LMA. We will be having laryngeal mask airway. That is laryngeal mask airway. I will be telling you how to understand, how to identify just by looking at the image. Okay, subsequently we will be studying that. Infraglottic devices that are going below the glottis, that is your ET tube, endotracheal tubes. Okay, and what are the adjuncts that we need to remember? Here we are having two type of adjuncts. First is oropharyngeal, first is oropharyngeal, and second one is nasopharyngeal. Second one is your nasopharyngeal. If you guys are feeling I'm going fast, you can tell me. Okay, till the time you should be understanding that ultimate purpose of this class, you should be understanding everything, right? So we are having laryngeal mask airway, we are having ET tubes, we are having adjuncts. Okay, so we can do the intubation now. Now the patient is in the OT itself. Okay, we are already giving the all the counter drugs that we need to give to calm down the patient. Now what we will be doing, the anesthesiologist will come and he will try to intubate the patient. He will be putting some kind of device to connect with the anesthesia machine or connect with the machines, right? So how this intubation is getting done, and what are the different airway devices that we need to study? We are having those devices which are working about the glottis, that these are known as supraglottic airway devices. The example will be LMA. We are having infraglottic airway devices, that the example will be ET tubes. Okay, and lastly we are having your adjuncts. These are the supportive devices. For example, we are having oropharyngeal, we are having nasopharyngeal adjuncts. Okay, oropharyngeal, what do we have? We are having, sir, Goodell's airway. We are having Goodell's airway. In nasopharyngeal, what we are having? We are having nasopharyngeal tubes. Okay, we are having nasopharyngeal tubes. Okay, don't worry, I will be showing you all the images. Okay, you will be understanding. All right, so let's start with the laryngoscope, guys. Please try to identify. They will give you direct question. They will be giving you the question. Please try to identify the device. Okay, just by giving the device, try to identify which one is this. First of all, Purane students, very good, Dr. Anonymous. Thank you, thank you. Okay, so what is that laryngoscope? What is that laryngoscope? First one, try to answer. This is your curved blade. You can see there is a curved blade there. Okay, this is your handle. This is, sorry, this one is your extra lever. Extra lever you can see, and this one is your handle. That is why I'm telling you guys, this is not Macintosh. This is not Macintosh. Why? Because Just try to understand. I am giving you simple points. If you understand these points, your life will be easy. Okay, anesthesia will be easy. Okay, here you will be seeing a source of light will be there. A source of light will be there. This is not Macintosh, guys. This is not Macintosh. This is your McCoy. This is your McCoy laryngoscope. How to differentiate? In Macintosh there is no extra lever. There is no extra lever in Macintosh. Okay, both of them are curved blade. Both of them are curved blade. That is why I put it this question. Okay, both of them are curved blade, but this extra lever will be absent in Macintosh. This is your Macintosh. This is your Macintosh. Okay, you will be finding that curved blade, but the extra lever will be absent. Okay, you will be having a source of light. You will be handling it in the left hand. You will be putting it inside and putting the tube, right? I will be telling you the steps of intubation also. Okay, this one is your straight blade. Look here, guys, this one is your straight blade. Straight blade. This is your straight blade. Straight blade, also known as Miller's, guys. This is known as Miller's laryngoscope. This is what we use in children's. Okay, बच्चे सीधे होते हैं, children's are like straight, you can remember like that. So that would be utilizing the straight blade laryngoscope, that is known as Miller's laryngoscope. Okay, this one you can see the structures on the screen. So this is your video laryngoscope. Okay, video laryngoscope. This one is your video laryngoscope. Okay, and this one we are using for rapid sequence induction, all those things when we cannot visualize the opening. That is your fiber optic laryngoscope. This is your fiber optic laryngoscope. Okay, so we are done with all different kind of laryngoscope. Important one that can be asked in your examination and as asked till now. So these are the important one that you should be remembering. Okay, now everything is clear. Please give me a confirmation if it is clear and you guys are understanding. Okay, so first of all, that is your laryngoscope. First laryngoscope, when you see this extra lever, that means curved blade with extra lever, that is your McCoy. That is your McCoy laryngoscope. Okay, curved blade only, that is your Macintosh. Straight blade, Miller's. Go directly with the Miller's. Video, you can see video laryngoscope. Apart from that, this type of structure, that is your fiber optic laryngoscopy. Okay, that is your fiber optic laryngoscopy. Okay, now please try to identify this given instrument. Okay, please try to identify this given instrument. This is your, what is this? Please try to identify this. Till then, I will be telling you the next part, that is your supraglottic airway devices. What we have seen about the laryngoscopes here. We are done with the laryngoscope. Now we are studying about the supraglottic airway devices. Okay, one by one we will be opening everything, right? So first of all, first thing that we are going to study is your LMA. That is your LMA. First thing that we are going to study is your LMA. Yes, this is LMA. This is a laryngeal mask airway. And which type? That is your I-gel. Sir, how do you know this is I-gel? How do you know? Okay, don't worry, I will be telling you how to identify these I-gel, which one is Supreme, which one is Pro-Seal, which one is what, right? So please try to be with me. I will be telling you. Okay, first thing, this is your classical airway. Can you appreciate a single opening? Okay, can you appreciate a single opening? And this is your pilot balloon. This is known as pilot balloon. And when you see a single opening, that is your classical LMA. That is your classical LMA. That is your classical LMA. Okay, look here, this one. Fast track will be having two openings, guys. Fast track will be having how many openings? It will be having two openings. Okay, extra handle will be present here. Extra handle will be present here, and this one will be a little bit curved. Okay, so that is your fast track. That is your fast track. Okay, Pro-Seal will be having again two opening. Pro-Seal will be having two opening, but this one will be straight. This one will be straight. Okay, so this is how you are going to identify. So three we have seen. First one is your classical single opening. This one is your fast track. Fast track will be having double opening along with the handle and along with the curve. Okay, this one is your straight blade. This is your Pro-Seal. This is your Pro-Seal. Okay, three we have seen. classical, fast track, ProSeal. Now coming on to next one is your this one. The important one is this one. This is your LMA Supreme. This is your LMA Supreme. Sir, how to identify LMA Supreme? Sir, this one will be curved. Along with that, there will be some fixation tape. Fixation tab. You will be finding this fixation tab here itself only. Okay, so you need to look for this particular structure. Okay, along with that pilot balloon, all those things will be there. This one will also be curved. How you will differentiate? This one will also be curved. Okay, so this fixation tab, when you are seeing, that means it will be having two opening. All second generation will be having two opening. Okay, it will be having two opening. So this is your LMA Supreme. This is your LMA Supreme, right? Next one, this one. Here you are finding no pilot balloon. No pilot balloon. So this is your eye gel. That was the question, guys. Okay, that was the question. This is your eye gel. And if you are finding this pilot balloon present, this is your LMA Ambu. I know it must be a little bit confusing for you for the first time, but just have faith in me. You will be when you are looking it for the second or third time, you will not make any questions wrong. Okay, and when you understand these key concepts, in the exam, they will be very helpful for you. Okay, so please try to revise again. Look here, we are having supraglottic airway devices. We are having classical, single opening, fast track, double opening with a handle. ProSeal will be straight blade. Okay, double opening. LMA Supreme will be curved along with the fixation tab. Okay, next one is your eye gel. Eye gel will be no pilot balloon, and lastly we are having LMA Ambu. Pilot balloon will be there, and this one will be again colorful. Okay, so these are the 6 LMA devices. Laryngeal, mask, airway. We can directly put these LMA devices. Okay, these are all your supraglottic devices. That means they are not going below the glottis, right? So these are the supraglottic devices. Now try to answer this question. So that would be your laryngeal mask airway. Now you can easily understand this is your eye gel. Clear funda, clear guys? Are you guys understanding? Right. Okay, next one. Please try to identify the given instrument. These are the questions that has been coming up in your examination. They are all the previous year questions I have taken from INI-SET FMGE examination, and they have asked this particular question. Now you easily understand. If there is a fixation tab, guys, if there is a fixation tab, that would be very easy question. That would be your, if fixation tab is present, that means this is your LMA Supreme, guys. This is your LMA Supreme. This is your LMA Supreme. Okay, so what is the answer here? They have given the simple option, and the answer will be laryngeal mask airway. Okay, laryngeal mask airway. Please try to answer this question. Where can the device in Murphy's eye can be observed? Okay, so Murphy's eye can be observed in which device, guys? Okay, so what we are seeing, the patient has already come to the OT. Now what we are doing, we need to intubate the patient. We have seen all the different kind of laryngoscope that we are having. We will be holding laryngoscope, we have seen. Now what we can do, we are having different devices. First one is your laryngeal mask airway. Second one is your what we have seen, laryngeal mask airways we have seen. Second one we are going to see is the ET tube. Okay, ET tube, endotracheal tubes. Okay, so now let's talk about the ET tube. What are different ET tubes that we are having? First of all, look here, guys. Okay, we are having ET tubes, and the question that they have asked you in your examination, that Murphy's eye will be present in which thing? Okay, so they have asked you the simple question. Please try to answer. Look here. Okay, endotracheal tubes. So these tubes are going into the trachea. We are having two type of endotracheal tube. We are having cuffed tube and we are having uncuffed tube. Okay, we are having cuffed and we are having uncuffed tube. Okay, what we are going to do, Murphy's eye. Okay, they have asked the question on the Murphy's eye. Very good, guys, very good. Okay, so what is happening, this end will be beveled. Okay, now what is happening, when they are putting the tube inside, because of some kind of blockage, they have made an extra opening that is known as Murphy's eye for the oxygenation. Okay, so what will happen if this opening will be blocked? What will happen, the patient will get oxygen from this part. Okay, then we are having this cuff, that is why they are known as cuffed tube. We are having this lining for the vocal tube guidance. Okay, vocal cord guidance. We are having this this is a 8 number tube, so that is telling us about the diameter of the tube. of the tube. And remember guys, diameter is very important. Why sir? Diameter, why it is important बच्चों? Because it is responsible for resistance of gases. Okay, it is responsible for resistance of gases. Okay, then we are having this particular connector. This is a universal connector. Okay, for example, nowadays all the chargers are coming like C type. That is how we are having all the devices having the universal connector, so we can connect anything. Okay, this is your again pilot balloon. We are that is for the inflation of the cuff. Okay, so these are all the structures that you have to see. Okay, so this is about the endotracheal tube. Okay, this is your Murphy's eye. Okay, now please try to solve this question. This is a FMG repeat question. Resistance of the tube shown below is primarily because of, किसकी वजह से होगा resistance? So I have already told you right here right now, so that is because of the diameter of the tube. Diameter of the tube will be providing the resistance guys. Okay, that would be providing the resistance. Okay, now please try to answer, what is this device called? Can you see double opening? Can you appreciate double opening here? Right, we can appreciate double opening, so that would be your double lumen tube. That would be your double lumen tube. Okay, so please try to look here, what are the different kinds of tubes we are having. Endotracheal tubes, we will be opening one by one. We will be understanding how to utilize the information and how to solve the question. Okay, so we are having multiple types of tube. First of all, let's start with the RAE tubes. First of all, let's start with the RAE tubes. Okay, RAE is basically the names. That is your ring, Adair, and Alvin tube. Ring, Adair, and Alvin tube. Okay, first simple thing that you need to identify, we are having two types of tube. One is south facing, one is north facing. So just remember, in the map, you know, नक्शे में क्या होता है, always north will be upward. Okay, always the north will be upward. Okay, so we are having north will be upward. Okay, so look here, this part is going upward, so this is a north facing tube. This part is going downward, so this is a south facing tube. Okay, south, both of them will be going in the same direction. As for south, as for same direction, just for the identification purpose, just remember simple thing, in the map north will always be in the upward direction. Okay, so look here, here the tube is going in the upward direction, that means it is a north facing tube. Okay, second one, south, this one is going in the downward direction, so this is a south facing tube. Okay, how you will identify outside? So both of them are going in the same direction, that is your south facing tube, and this one is your north facing tube. Okay, so this is how you will be understanding first tube. Second tube is your, this is your red rubber tube. This is your red rubber tube. When do we use this kind of red rubber tube? For example, we are doing some kind of a CO2 laser surgery. Okay, we are doing CO2 laser surgery, then we are using this type of red rubber tube. Okay, next one, this tube is a kink resistant tube. This tube is kink resistant tube. They are basically flexometallic tube. They are basically flexometallic tubes. Okay, they are basically flexometallic tubes and they are kink resistant. That means when you are doing surgery in the prone position, you know, this tube will be this tube can be utilized for such kind of a surgery, you know. Okay, so it won't kink when you try to lift the patient here and there. It won't kink and the patient can be done easily. The surgery can be done easily, right? This one is your boogie and this one is your stylet. These are the things we are using to guide the endotracheal tube. When we are guiding the endotracheal tube, we can use these things. Okay, and this one is the question, that is 2 lumen. You can see, you can appreciate 2 lumens here, so that is your double lumen tube. That is your double lumen tube. We will be summarizing everything. Okay, this is your double lumen tube. Okay, this is for one lung ventilation. This is we utilize for one lung ventilation. For example, one lung of the patient needs to have some surgery, so what we do, we just put the tube in the one lung. We will be inflating the one lung only, and the other lumen will be going into the another lung. Okay, so that is the one lung ventilation tube. Okay, that is the double lumen tube. Okay, we can utilize it for the single lung ventilation. Okay, so try to look here, we are having different kind of tube. First we have seen the RAE tubes. North will be upward facing, south will be downward facing. Okay, kink resistance, flexometallic tube, red rubber tube for CO2 laser surgeries. Okay, this one is your boogie, this one is your stylet, they are for the easy insertion of the tubes, and this one is your double lumen tube that is utilized for a single lung ventilation. Are we done till here? Clear, guys? Okay, next thing is your adjuncts. Okay, we have seen the laryngoscope, we have seen the LMAs, supraglottic airway devices, we have seen the infraglottic airway devices. Now we are looking at some adjuncts. Okay, what are the adjuncts that we are having? We are having two types of adjuncts. One is one is oropharyngeal, second one is your nasopharyngeal. Okay, look here, guys. First one, this structure that you are seeing is a oropharyngeal device. That means it will be going through the mouth. Okay, what do we call it? That is known as Goodell's airway. This is known as Goodell's airway. And what is happening here? How we are going to put this Goodell's airway? The tip, remember guys, the tip should be facing the roof of mouth. The tip should be facing the roof of mouth. And how do we assess the size? These are the two important questions they will ask you. Three questions till now that they have asked you. First thing, identify the device. Second question, how do we insert it? So how we will insert it? The tip should be facing the roof of the mouth, and then we will rotate it. How much we will rotate it? 180 degree. Okay, and how do we assess the size of this particular device? We will assess the size from angle of mouth to the angle of mandible we will be using the angle of mouth to the angle of mandible. Look here, guys, we are utilizing the angle of mouth to the angle of mandible. Okay, we can use this oropharyngeal devices. Okay, we can also use nasopharyngeal devices. Okay, and the one question that they have asked you about the nasopharyngeal devices, how do you assess the size for nasopharyngeal devices? So you will be assessing the size from tip of nose to tip of ear lobule. You will be assessing the size from the tip of nose to tip of ear lobule. That is how you are going to utilize the size of this oropharyngeal and nasopharyngeal airway devices. Okay, till now we have understood what are the different type of devices we are having. Let's recap everything fast. Okay, so what are the different devices we have seen? I really hope you guys are understanding. Okay, so we are doing intubation. The patient is already come into OT. Now we are doing intubation. We are putting laryngoscope. What are different kind of laryngoscopes? Now you already know. Second thing, supraglottic airway devices. These are your LMA. Infraglottic airway devices, these are your ET tubes. Okay, and the adjuncts that you are putting, we are having oropharyngeal, we are having nasopharyngeal. For example, Goodell's airway, we are having nasopharyngeal. For example, the patient is unconscious, you cannot open the mouth, you cannot put directly. What you will do, you will be putting some kind of a Goodell's airway, and then you will visualize everything, right? Okay, so that is your ET tubes and all these adjuncts devices that you can utilize. Okay, I hope everything is clear till now. Do let me know in the chat box, guys, everything is clear, so that we can proceed. Are you guys understanding? Okay, and please try to solve this particular question. Which of the following statement is false regarding the intubation, guys? Which of the following statement is false regarding the intubation? Morning sniffing position, flexion of neck. Yes, correct. Okay. Second, introduce the laryngoscope from the right hand. Maybe. This one is true. Push the tongue away and see epiglottis and then visualize the glottic opening. Yes, very correct. Introduce the ET tube and inflate the cuff. Right. Check for bilateral breath sounds and fixation of the tube. Right. So everything is right except the point number 2. Very good, Pradeep. Very good, Mihir. So the answer here will be introduce the laryngoscope from the right hand. Now what we are doing, you already know all the structures, all the things. Now what is happening? The patient is lying down. Now you need to intubate the patient. Okay. So first of all, you need to make the morning sniffing position of the patient. First of all, you need to make the morning sniffing position of the patient like that. Okay, then you will be introducing the laryngoscope from the left hand always. Okay, you will be introducing the laryngoscope from the left hand always you will be putting like that, and then you will be pushing the tongue away, and then what you will be seeing, you will be seeing the epiglottic opening, glottic opening, you will be seeing the vocal cords. Then what you will do, you will try to put the ET tube. Okay, you will be having some markings, you will be putting the ET tubes. Then what you will do, you will inflate the cuff. Okay, and then you will check for the sounds and fixation of the ET tubes. With the last part, you will be connecting it to the capnography, and you will be identifying whether it is placed on the right place or not, right? So here the answer will be B. Okay, answer here will be B. You will always be carrying laryngoscope in the left hand, guys, left hand. Okay, always in the left hand. Please try to answer this. What is the specific action being demonstrated in the provided image? What is this action? Is this a head tilt or chin lift? Or is this a jaw thrust or head extension or inline manual stabilization? What is that? Please try to answer this. And this one also, what is the specific action being demonstrated in the provided image? So look here, guys. Here we are having, just look at the head. If he is holding the head, that means this is a head tilt and chin lift. This is a head tilt and chin lift. Very good, Mihir, Nandini, Nidhi, Palak, Muskan, everyone. Very good. Okay. Second one is your this maneuver. We are not touching the head. Here we are having jaw thrust. Okay. For trauma patient, we are doing jaw thrust. These are the things we will be utilizing when we need to visualize the glottic opening. Okay, when we need to visualize the glottic opening. So we are having two maneuvers. We are having head tilt and chin lift. They have asked the question based on the image. Okay, so first one is your head tilt and chin lift maneuver to visualize the glottic opening. That means they are put one hand on the head, second hand is on the chin. Second one is your jaw thrust maneuver for trauma patient, because we cannot put pressure on the atlanto-occipital joints. Okay, so we will be using this type of thing. Okay, that is your jaw thrust. Okay, now this one is your Salix maneuver. This one is your Salix maneuver. We are doing this particular maneuver to prevent aspiration. What we are doing, basically we are putting pressure on the cricoid cartilage. Okay, if we are putting pressure on the cricoid cartilage, what will happen, we will try to prevent the aspiration. For example, this Salix maneuver we are using in like rapid sequence induction we can use this type of maneuvers. Okay, so to prevent, basic function will be to prevent the aspiration, okay, while intubation. Okay, so that is the Salix maneuver. Okay, we will be putting pressure on the cricoid cartilage to prevent the collapse. Okay, now the patient is already intubated. What we have done, we are putting the laryngoscope, we are putting the different tubes in the patient. We have already fixed the tube. Now what will happen, the patient will look here and there, because till now we have not given any kind of anesthesia. The patient is awake. So what will happen, just for the story purpose, so what will happen, he will be looking here and there, and he will be finding some kind of monitors. Okay, he will be finding some kind of monitors in the room, and he will be asking the question, doctor, please tell me what are those monitors. Okay, so look here, what are those monitors. We are having anesthesiologist have given some standard guidelines. So we are having standard 1 and we are having standard 2. Standard 1 means that every OT should be having a registered anesthesiologist. That is normal. Or second, standard 2 will be every OT will be having these 5 mandatory monitors. Okay, these 5 mandatory monitors. And what are these 5 mandatory monitors? Let's see one by one. The first one is your ECG, second one is your SpO2, third one is your NIBP, and lastly we are having temperature. Along with that we are having capnography. Okay, so let's start one by one. We are having ECG. You must have seen this kind of monitors in your OT as well, right? So first one we are having is your ECG. We will be looking for the lead number 2, because lead number 2 will be telling us about the arrhythmias. Okay, if the patient is having arrhythmia, we can see it in the lead 2. Okay, and lead 5 generally will tell us about the MI. Most common that would be, so lead 2 and lead 5 will be there in the ECG. Okay, second one is your SpO2 is pulse oxygen saturation. Okay, the device we are using is pulse oximeter, and it is based on the law that is known as Beer-Lambert's law, or also known as law of plethysmography. Okay, Beer-Lambert's law or law of plethysmography. Okay, this one is your capnography, guys. This one is your Capnography will be measuring the levels of EtCO2, okay, expired CO2, okay. This one is your non-invasive BP monitoring. We will be having a cuff that is automatically inflated, okay, and then we are having a temperature probe. The most sensitive will be pulmonary artery catheter, but that is an invasive process, so we are using we can use lower one third of esophagus for monitoring of the temperature. This is not the normal body temperature, this is the core temperature, core body temperature, okay. So we are using that temperature probe, and then we can look for all these things, okay. So these are the five mandatory monitors. First one is your ECG, second one is your SpO2 telling us about the oxygen saturation of the patient, third one is your capnography telling us about the expired CO2, how much amount of CO2 is coming out, telling us about the intubation is done or intubation is going fine or not, okay. Next one is your non-invasive BP monitoring. It will be telling us about the BP of the patient, okay, and temperature of the patient, okay. So these are the important thing that we need to look for, okay. So these are the monitors that should be present in your OT, okay. Now the patient is in the OT itself. Now let's see what we can do, what other monitors can be there, and this was the question they have asked you. Please try to answer this question. What is the most frequently employed method of monitoring the level of anesthesia? How we can yes, I will tell you about the types of capnograph we will be studying. Don't worry, everything is incorporated, okay. Just be with me till the end. You will be understanding everything, okay. What is the type of frequently employed method for monitoring the level of anesthesia? Whenever you see this kind of picture, this is your what kind of index? That is your bispectral index. This is your BIS monitoring, okay. That is your bispectral index monitoring, okay. How we are using it and what it will be telling us about. Let's see how many other monitors that we are having here, okay. So the first one is your BIS. The meaning of BIS is bispectral index. This is your bispectral index, okay. It will be telling us about what, guys? It will be telling us about the depth of anesthesia. It will be telling us about the depth of anesthesia. The levels here, the levels will be 0 to 100. Here the levels will be 0 to 100. 0 will be telling us the patient is in the coma, okay, and 100, that means the patient is fully awake, okay. During anesthesia, what we need to do, we need to make the patient in somewhere in between 40 to 60. So what will happen whenever there is decrease in the decrease in the level? What we need to do, we need to decrease the dose, okay. We need to decrease the dose of anesthesia, and what will happen, sometimes it will be going above 60, so that means patient is awakening, right? So what we need to do, we need to increase the dose of anesthesia, okay. So that is how it is important monitor, that is BIS. But this is desirable monitor, not so necessary. Five mandatory are different, this one is extra monitor, okay. Apart from that, we are having this one. This one is your neuromuscular monitoring. This one is your neuromuscular monitoring. This is done for which nerve and what is happening here? So look here, this is done for most common nerve that we are using here is ulnar nerve, okay. This one will be telling us about the adequacy of muscular blockade, okay. So when we are giving neuromuscular blocker, so we will be checking whether the muscles are adequately paralyzed, okay. So we will be using this neuromuscular monitoring, that is your neuromuscular monitoring. We will be using which nerve? That is your ulnar nerve, okay. Apart from that, we are having this type of catheters also you will be finding. This one is very simple, you will be encountering this in your internship also. That is your central venous catheter. This is your central venous catheter, and this one is known as swan. This yellow thing is known as swan Ganj catheter. This is known as swan Ganj catheter, and this is the particular thing we are using for pulmonary artery catheter. This is also known as pulmonary artery catheter. This one will be having the thermometer here. Look at how to solve the question, okay. That is what we are doing. What is the most effective approach for verifying the accuracy of intubation during laryngoscopy? How do we do that? We will be we will be attaching our system to what? Answers, guys. Yes, that is your, what is this? This is the answer will be capnography. Okay, capnography. What is the most effective way to verify placement of endotracheal tube in a 30-year-old male patient who has been intubated for surgery by a final year resident? So guys, they are basically, what they are doing, they are changing the language. Okay, they are, both of them are the question, repeat question. Basically what they are doing, they just want to know the exact thing, right? What is the exact thing after intubation? For confirmatory diagnosis, what we are going to do, we are going to put capnography. We are going to put capnography, and this is the, it is a mandatory monitor, right? Capno means what, sir? It will be checking the levels of expired CO2. Okay, so what it will be telling us about the metabolism in the body. Okay, whatever metabolism that will happen. Metabolism is what, sir? Metabolism is sum of catabolism plus anabolism. It is the sum of catabolism plus anabolism. So whatever reaction that are happening in the body, catabolism means what? Catabolism, large particles are broken down into simple substances. For example, you are eating food that would be converting into glucose, that is catabolism. Okay, anabolism means what? Multiple glucose molecules binded together making what? That is making amino acids, proteins, that is anabolism. So this kind of steps that are happening in the body, that is known as metabolism. And capnography will be checking, will be telling us about the CO2 levels. It will be telling us about the levels of CO2 which is coming out. Okay, which is coming out. So look here, we are having this graph, we are having this graph. Okay, so what are the different things that will happen here? Look here, this is the phase 1, this is phase 2, this is phase 3, and this is phase 0. So what will happen, what we are doing basically, this is we are putting the endotracheal tube, and now we are connecting the machine through the endotracheal tube, and we are seeing certain kind of graphs in the screen. This type of graph we will be looking in the screen, and this one will be telling us about the expired CO2. Whatever CO2 is coming out from the lungs will be shown as a graph on the screen, right? That means till the time CO2 is coming in, from the lungs, that would be shown as a graph on the screen, right? So this is the phase 1. Phase 1 will be stable, right? This is the respiratory baseline. Now what will happen, CO2 will come out, it will come out and will be because of expiration it will be coming out. Okay, and that would be showing us the phase 2. Now what will happen, it will be showing phase 3. That is the time when the gases are in the alveoli, that means mixing is happening, right? And then what will happen, we will inspire, right? Because of inspiration, what will happen, the levels will again go down, levels of CO2 will again go down. Okay, so that is the three things. Okay, is it fine? Internet is fine, some glitches there, I don't know. Do let me know if I'm clearly visible and audible. Okay, I can repeat if something is lost. Okay, so that is the phase telling us about the inspiration, this one is telling us about the expiration. Okay, there is a question that they have asked you, where do we measure the levels of EtCO2? Whatever levels like 35, 40, 45, whatever levels that we are seeing, we are measuring those levels at the end of, remember guys, this was the question of I said, at the end of phase 3. Okay, because I think you have to solve all the question. Basically, I have incorporated more than 100 question in this particular PDF. Previous year 4 to 5 years questions are here. Okay, so what you need to remember, the questions are taken up by the same board, right? Same board is taking your examination, NEET PG examination, so you need to solve all the questions. Okay, right now you don't have much time, so on the Meduhub we guys are having like PYQ sessions. I would be conducting more sessions, so you will be joining. Okay, and you can join for that. Okay, so basically what we are looking here, at the end of phase 3 you will be finding, at the end of phase 3 you will be measuring the levels of EtCO2. Okay, EtCO2 levels will be measured on phase 3. Okay, this is your normal capnograph. What is the normal EtCO2 level? That is your 35 to 45 mm of Hg. Okay, kitna hoga? That is 35 to 45 mm of Hg. Okay, next thing, this type of pattern. Okay, now you need to remember, certain patient exam is coming soon nearby, we cannot go into more details, so I would be telling you the important points only. Okay, so this is your shark fin pattern, this is your shark fin pattern that you will be finding in partial obstruction bronchial asthma, and bronchospasm. Okay, so whenever you see this type of pattern, just remember there is some problem in the bronchus. Okay, there is some problem in the bronchus itself. That is due to partial obstruction. It can be due to bronchial asthma. It can be due to bronchospasm. Okay, if you are finding this type of cleft, okay, this type of cleft you are finding, this is known as curare notch. Okay, this is known as curare nose, and this one will be telling us about the return of spontaneous ventilation. This one will be telling us about the return of spontaneous ventilation. What is the meaning of spontaneous ventilation? That means patient has started inspiring and expiring himself, right? So that is the return of spontaneous ventilation. We can see it on the screen and we can identify, right? Next thing, this one is your above the baseline. Above the baseline graph you will be finding in the cases of CO2 rebreathing, when your soda lime can be expired. Okay, so that means it can be a problem in the circuit itself, or soda lime has expired. So these are the cases where you will be finding the graph above the baseline. Continuously CO2 will be rebreathed, and because of that what will happen, there will be above the baseline graph. Okay, next thing, please try to answer this question. What is the parameter being assessed by the device depicted in the provided image? What is this device, guys? And what does it measures? Yes, this is your pulse oximetry. You must have seen in the COVID time. This is your pulse oximetry. Okay, and this one will be telling us about the oxygen saturation. Okay, this one will be telling us about the oxygen saturation of the blood. Okay, oxygen saturation will be telling. It is based on two important law, that is Beer-Lambert's law, and law of plethysmography. No need to go into detail for now, just remember this thing. Okay, so this one will be telling us about the oxygen saturation. Okay, next one, clinical case. A 40-year-old patient is undergoing surgery under some anesthetic drugs. Suddenly during surgery his EtCO2 values are crossed more than 100 mmHg. I have told you 35 to 45, along with high temperature of the body. What could be the possible scenario for this particular reason? Except, try to answer this question. I want to know what you guys will mark. Hello Then for this one. Nandini, Muskan say C. Very good, Muskan. Look here, guys. This is a tricky question. Please try to read the question carefully. What they want to know, what they want to ask. Okay. What is the diagnosis? What do you guys think? What is the diagnosis here? Here they have already written except in the question. I know you guys have already suspected malignant hyperthermia, but examiner is smart, right? He know where you guys will mark the wrong answer. Okay, so diagnosis here will be malignant hyperthermia. Very, very important situation. They have given multiple questions. I have put it only one, but they have given multiple questions based on this, right? So what is happening? Okay, A was the answer for previous question, right? Okay. Try to answer here. Here also the answer here will be C. Look here how. Okay, so we are giving acetylcholine, or we are giving succinylcholine. Succinylcholine and acetylcholine both are like brothers. Okay, so what will happen? They will be activating. Let me tell you the mechanism how this is happening. They will be activating a receptor that is known as ryanodine receptor. Okay, it will be binding from physiology. I would be telling it will be binding for DHPR. Okay, and ultimately causing the release of calcium. Okay, it will be binding with DHPR will be going to sarcoplasmic reticulum, that would be asking some calcium, and ultimately leading to increase in the levels of calcium, and calcium will be causing contraction. Remember guys, from physiology, from medicine, calcium will be having always three functions. First one, constriction. If it is in the vessel, it will be causing vasoconstriction. Second is contraction. If it is in the muscle, it will be causing contraction of the muscle. And third function is exocytosis. That means whenever calcium will enter, something will go out. Okay, so these are the three important function of calcium, important ones. Okay, so what will happen? It will be causing muscle contraction, and because of vigorous muscle contraction in the body, what will happen? The metabolism will increase. Leading to increase in temperature. Okay, it will be leading to increase in temperature. Okay, so this is the malignant hyperthermia. This is the case of malignant hyperthermia. How you treat this particular situation, guys? With the help of a drug, that is IV sodium dantrolene. Okay, this is the drug that you are using, that is IV sodium dantrolene is the drug of choice for malignant hyperthermia. What will happen? There will be increased metabolism in the body. What will happen? Because of that increased CO2 levels, okay, you can see here the CO2 is rising. You can see in the graph the CO2 is rising. Because of that, this is known as malignant hyperthermia. All the inhalational agents, this is the most important question I am expecting again. All inhalational agents can cause malignant hyperthermia, right? This one is inhalational, this one is inhalational. Apart from that, succinylcholine is the most important that you should be remembering. Apart from that, succinylcholine, which one will not cause? Except the answer will be propofol. The answer will be propofol here. Okay, next thing, a 46-year-old chronic smoker comes to the emergency department. There is a smoker who is coming to the emergency department with a history of breathing, difficulty in breathing, that is dyspnea, fever from last 1 day. Okay, which of the following pin index number cylinder will you use here? So you will be using what? Which gas? You will be using oxygen, and pin index we will be remembering just now. Okay, till then try to answer this question. Okay, second question, which color combination is commonly associated with nitrous oxide cylinder? Okay, nitrous oxide cylinder, which color it will be giving? Try to understand. Okay, so you need to remember the pin index. Now you guys are understanding what we are studying, right? You need to remember the pin index. Second thing, you need to identify the color of the cylinder. Then we will come back to these questions. Okay, so before that, let's recap everything that is about the that is now we are going to understand about the anesthesia machine. Okay, till now what we have done, guys, till now what we have done, look here, till now what we have done, we are done with the introduction part. We have seen all the different kind of anesthesias we are having general, regional, local anesthesia. Then we have seen the pre-anesthetic checkup. What is that pre-anesthetic checkup? Then we have done the intubation. Now you already know how to do the intubation. I'm not going into details, but the superficial one, so that the story will get stuck in your mind. Okay, then we have seen the different kind of monitors, like what are those monitors? Okay, now we are studying about the anesthesia machine. Okay, after that we will be studying about the circuits. Okay, so now we will be discussing about the anesthesia machine. Okay, so now we will be discussing about the anesthesia machine, guys. Just now we will be discussing about the anesthesia machine and what are the different things that you need to discuss about these machine. Look here, guys, first thing, what is the function of this machine? Okay, why do we need this particular machine? Why do we need this anesthesia machine? Multiple answers I am getting for the question. Okay, try to answer. First thing, to decrease the pressure, oxygen cylinder is having too much pressure, 2000 psi, nitrous oxide 760 psi, too much pressure. We cannot, our lungs cannot tolerate such kind of a pressure, right? So what we need to do, we need to decrease the pressure, first thing. And second thing, we need to add some kind of drugs like halothane, sevoflurane, isoflurane, all those inhalational agents. We need to mix them in a mixed known concentration. Because of that, we are having this anesthesia machine. Okay, so we are having this anesthesia machine. The function will be two and understandable. First thing, it will be decreasing the pressure. Second thing, it will be mixing all the things, right? So this is your anesthesia machine you will be finding in your OT, right? You will be having all those monitors, all those vaporizers are here. I would be telling you how it is looking, right? So we are having three type of system in this particular machine. We are having high pressure system, we are having intermediate pressure system, we are having low pressure system. Okay, three type of pressure system: high, intermediate, and low pressure system. Important things, what are the important things that are coming from high pressure system? Look here, guys, high pressure system, the important one that you have to remember is about the pin index safety system. First one is your pin index safety system. I am telling you all the answers. Wait. Okay, so first one is your pin index safety system. Why do we need this system? क्यों चाहिए ये? To prevent, we need this to prevent, ये चाहिए हमको to prevent the incorrect attachment, to prevent the incorrect attachment of cylinders. We need this kind of system to prevent the incorrect attachment of cylinders. For example, some of you, like, you must be naughty, so what you want, आज चलो नाइट्रस ऑक्साइड का सिलेंडर लगा देते हैं ऑक्सीजन की जगह. What will happen? That is a laughing gas, right? Patient bye bye हो जाएगा आस्ते आस्ते, right? So to prevent this type of error, to prevent this type of thing, what we are using in the high pressure system, we are having PIS, that is pin index safety system, that is for the prevention, right? Then what are those pin index? You can remember, we are having air, we are having oxygen, we are having nitrous oxide, we are having CO2, okay, we are having cyclopropane, and lastly your Antonox. Okay, so air will be 1, oxygen will be having 2 molecules, N2O 2 3, that would be 3, just add 5. Okay, so these are the pin index for air, oxygen and nitrous oxide. Air will be 1 5, okay, oxygen will be 2 5, nitrous oxide will be 3 5. CO2, if it is more than 7.5%, that would be 1 6. Okay, C is looking like 6, just remember like that. So if it is more, it is 1 6, if it is low, it is 2 6, and lastly we are having cyclopropane, that is 3 6. Okay, and you can count the number here, 1 2 3 4 5 6 7, so that would be 7 is the Antonox. Antonox is what? It is nothing, it is N2O and oxygen mixture. Okay, Antonox is what? N2O and oxygen mixture. Okay, that is your Antonox. Okay, just try to understand. So now you understand the pin index of everything, right? So in this question, in that question, they have asked about the oxygen. The patient is having dyspnea, right? So what is the pin index that we are using? That is for the oxygen, that is your 2 5. Okay, that is your 2 5. Okay, now let's talk about the color. Color will be, air will be having, air will be having black body and shoulders will with black and white quarters. Okay, air will be having black and white shoulder with black body, oxygen will be black body, white shoulder. N2O, N2O कैसा होगा? नीला होगा. Carbon dioxide will be gray. Cyclopropane in Hindi we call it santri, so that would be oxygen, sorry, that would be orange in color. Okay, Antonox, Antonox is a mixture of N2O plus oxygen, so that would be blue body, and shoulders will be blue and white. Okay, shoulders will be blue and white. You have to remember these. So this is for the black body, white shoulder, that is your black body, white shoulder, that is your oxygen. Very good. Okay, this one is your blue cylinder, blue means Neela, and Neela will be N2. Okay, this one is your orange, orange is Santri, so that would be your cyclopropane, cyclopropane. Okay, these are the important ones. Okay, can you appreciate these are the pin index? Okay, these are the pin index, and for this particular cylinder, these are the pin. Can you appreciate? These are the pins, right? These are the pins. Okay, so these are the pin index that we are utilizing for the high pressure system. Okay, it is the component of the high pressure system. High pressure system, we are done with that. Okay, second one is your intermediate pressure system. Okay, so when you go to your OT, you must be seeing in your hospital, you must be seeing different kind of pipelines over the roof, right? So what are those pipelines, and which are the gases that are running in those pipelines are coming under the intermediate pressure system, right? Here in high pressure, the pressure will be around 2000 psi, that is too much pressure. Here the pressure will be intermediate, that would be 55 to 60 psi. Okay, so that is running in your hospital, right? So near the patient bed you will be finding such kind of things, right? So that is your intermediate pressure system. What are the important points that you need to remember about this? First one is your emergency oxygen flush. Just remember this question whenever you will see. This is the question they have asked you 2 times. Emergency oxygen flush is a part of intermediate system. Emergency oxygen flush is a part of intermediate system. Flow control valve are the basically color coded valve. I will be telling you about that. Here you will be having DIS. What is DIS? DIS is nothing but diameter index safety system. Just like the pin index safety system, here we are having this, that is diameter index safety system. Okay, so here we are having for the air, vacuum, oxygen and nitrous oxide. Okay, so we are having four cases. Okay, so air, just remember air will be black everywhere, so that would be your black in color. Vacuum, just extend the V into Y, that would be yellow. Oxygen will be very important, so you can remember that would be white. And N2O, here again it will be Nila, that would be your blue. N2O will be blue. Okay, so when you are going into your hospital, you will be finding these lines which are going around, and they will be having flow control valve. Okay, just like a cup like a thing you will be seeing, you will be opening the valve, that would be humidifying the gas, and the gas will be coming to the patient's bed. Okay, so near the patient bed there is a valve, you can see, and different color of gases are coming there, right? So what are in those color pipelines? In air will be in the black color pipeline, vacuum will be in the yellow color pipeline. Okay, oxygen will be in the white color pipeline, and N2O will be in the blue color pipeline. Okay, so these are the important one that you should be remembering. Okay, so that is a part of diameter index safety system, and the pressure here will be intermediate, it will be an intermediate pressure. Okay, lastly we are having low pressure system. We are talking about the anesthesia machine, it will be having three parts. Lastly we are having low pressure system, it will be having some kind of flow meters. Okay, flow meter will be telling us about the flow of gases. Okay, we will be having some kind of vaporizers. Important one, vaporizer will be having what? They will be having your gases like your halothane, sevoflurane, isoflurane, desflurane. Okay, so just remember like that. You will be remembering सूरज कैसा होता है? सूरज is yellow, so that would be your SIVO. SIVO will be yellow color. Okay, purple will be isoflurane. Okay, halothane is not so much used now, so it will be red in color. And this, look here, these three chambers are looking same, they are looking exactly same, but this one is looking a little different. Okay, so that is the different vaporizer we are using. We are using this different vaporizer, that is known as Tech 6 vaporizer. That is known as Tech 6 vaporizer, and this one is used for a special gas, that is desflurane. Important one, guys, this one is different. So the color will be blue, the color will be blue. This one is the different one, and the color will be blue. So we are having four type of vaporizers: CO, ISO, halo, and des. Okay, CO, ISO, halo, and des. These are the four types of gases which are put in the vaporizer. Okay, so please try to solve this question. Blue pipeline supplies carries which gases? Blue pipeline, that would be nitrous oxide, that would be nitrous oxide. So we are done with all the anesthesia machine. Anesthesia machine will be having three important parts. We are already done with that. We are having high pressure system, intermediate, and low pressure system. In high pressure system, two important points: one is about the pin index system, and second is about the color of the cylinder. These two questions are being asked. Second one is your intermediate pressure system. From intermediate pressure system, they can ask you question based on this. Apart from that, they can ask you question from emergency oxygen flush, and third thing will be flow control valve. Okay, color you should remember: air will be black, vacuum will be yellow, oxygen will be white, and N2O will be blue, right? Next one is your low pressure system. Low pressure system, we have seen the vaporizers. What are these four vaporizers? They are different color given to everyone, right? CO will be yellow, ISO will be purple, okay, halo will be red, and desflurane will be blue in color. Okay, desflurane will be blue in color. Blue color will be nitrous oxide. Pipeline will be having nitrous oxide. It is a part of intermediate system, it is a part of intermediate system, right? Next one, the best way to recognize the cylinder. How do we recognize the cylinder? This is a previous year question, please try to answer this. What is the cylinder associated with a black body and white shoulder? Please try to answer this also. So that is the label, guys. Okay, label is the best part. Label is the best part to recognize the cylinder. Okay, what is the cylinder associated with the black body and white shoulder? Try to answer this. Yes, that is your oxygen cylinder. That is your nothing but your oxygen cylinder. These type of questions they are asking, right? The color of nitrous oxide cylinder, they have asked this question multiple times. Okay, multiple times they have asked this question. So that would be completely blue. Blue cylinder will be nitrous oxide. Okay, now we have seen the anesthesia machine. Okay, now we will try to connect the anesthesia machine to the patient. Okay, our patient is lying down, we have intubated our patient, this is your machine. Now you need to connect your machine to the patient. Now how will you connect your machine to the patient? Okay, you need some kind of a circuit, right? You need some kind of a circuit to connect to the machine to the patient, and these circuits are known as these circuits. These are the circuits that will be required. These circuits are of three types. We are having, very good guys, we are having three types of circuit. Just try to understand. We are having open circuit, we are having semi closed, and we are having closed circuit. Okay, so open circuit means directly putting the drugs. For example, you must have seen in the movies what some people are coming in, they are putting chloroform on the someone, and they will be getting unconscious, but this is not the things are happening in the real life. Okay, for example, we have tried ether, right? So pouring the agent directly is the open circuit, that is not used now. Second one is your semi closed, and third one is your closed. Okay, closed we are using in the OT, and semi closed for the for other places. Okay, it is a portable circuit. Semi closed is a portable circuit, and the most of the questions are coming from this particular thing, right? Please try to give your attention for like 10-15 minutes, and you will be understanding everything. Okay, that is your Mapleson circuit. Okay, that is your Mapleson circuit. Try to look here, we are having these type of circuits. Okay, we are having open circuit, closed circuit, and semi-closed circuit. Semi-closed are the most important ones. You are getting questions from these. Okay, multiple questions, approximately 15 to 20 questions has been asked till now from this particular things, right? So we are having Mapleson A. Just remember the way I'm telling you. Look here guys, Mapleson A, just remember A means alone. Okay, Mapleson A will be alone. If someone is alone, what it will do, it will do what kind of breathing? Spontaneous breathing means अपने आप जो सांस लेता है. ओके, अपने आप जो कर रहा है, दैट इज अलोन. अगर कोई अकेला होगा तो क्या करेगा? ही विल मेक द मैगी, he will cook the Maggie and eat alone. Okay, so it is also known as Meigels circuit. It is also known as Meigels circuit. Okay, Mapleson A is a spontaneous circuit. अकेला रहेगा तो खुद ब खुद क्या करेगा? मैगी बनाएगा, मैगी खाएगा. That would be your Meigels circuit. Okay, we are having a modification of it that we will be studying, that is known as modified Mapleson A, and this is also known as Lex circuit. What is the other name of this? This is also known as Lex circuit or coaxial Mapleson A. I would be so let you solve the questions. B here bus. Okay, B and C, they are not used now. Just remember about the D, and D1 is dependent circuit. D1 is dependent circuit. Okay, so we are using this, it will be dependent on someone, so it will be dependent on whom? Someone, right? So that is known as Bain circuit. This is also known as Bain circuit, and this is used for what kind of ventilation? This is used for controlled ventilation. Try to understand the meaning of spontaneous and controlled ventilation. Spontaneous ventilation मतलब क्या है? पेशेंट अपने आप सांस ले रहा है. कंट्रोल वेंटिलेशन मतलब क्या है? पेशेंट कैन नॉट ब्रीद ऑन देयर ओन. कंट्रोल वेंटिलेशन मीन वी आर कंट्रोलिंग द वेंटिलेशन, राइट? सो फॉर दोज पेशेंट्स for whom we need to control the ventilation, that in those patients we will be using this circuit, that is Bain circuit. किसी पे डिपेंड रहेगा, किस पे डिपेंडेंट? यू कैन रिमेंबर बहन पे डिपेंडेंट है, बैन पे डिपेंडेंट है. ओके, दिस इज ऑल्सो नोन एज कोएक्सियल Mapleson D. Okay, this is A, this is your D. Okay, E is your Ayers TPs. This is a useless circuit, we don't use it now. Okay, and E का modification हुआ, that is your F circuit, that is known as Jackson-Rees modification of IRTPs. Okay, so basically Jackson-Rees modified this particular circuit. It do not have a bag or valve, so what he has done, he has added the valve, right? He has added the valve to this particular circuit, so that is known as Jackson-Rees modification of IRTPs, and it is the circuit of choice in pediatric patients. In any kind of ventilation in pediatric patient, the circuit of choice will be this one. Okay, for both controlled and spontaneous ventilation, what is the thing that we are using? That is your pediatrics. For pediatrics patient, controlled ventilation, spontaneous ventilation, circuit of choice will be Mapleson F always. Circuit of choice will be Mapleson F. Now the question, how you will identify, how you will classify them, right? This is this is the diagram. Let me tell you, look here. Okay, so these are the diagrams. If they give you as step ahead questions, till now they do not have asked such type of question in FMG examination, but just look for a minute, it is very simple. Okay, so just remember adjuncts. Okay, that means this is your valve. Okay, and we will always talk in response to patient's end. Okay, so if both the things are together, they are adjuncts, that is Mapleson A. Okay, just remember that is Mapleson A for adjuncts. Okay, B means what? This is your Mapleson B. In B, fresh gas flow and FPL and this thing, all three things will be together. So just remember both of them are together. Okay, both of them are together. C means here you will be finding no corrugations. Okay, so C means corrugations will be absent. Corrugations will be absent. Okay, yes, F will be used for pediatric, right? This one is your D. D for distant. D for distance. That means this valve is distance. Okay, here this valve is distant, here it is near, here it is distance. Okay, E and F. For E and F, E and F are bagless and valveless. They do not have valve, they are valveless. Okay, in the F you will be finding a balloon, in E you don't find a balloon, right? This is how you will be identifying these circuits. And because E and F do not have balloon, so it will be decreasing the resistance. Okay, it will be decreasing the resistance so that gases can easily go to the pediatric patients, right? So this is how you will be understanding. So A will be adjunct. Adjunct means what? The wall will be adjunct. Here the wall will be adjunct the patient's end. B will be both the wall and the fresh gas flow will be nearby. C will be no corrugations. D will be wall will be distant. E and F will be valveless. F will be having a balloon. This is how you will be understanding these circuits. Okay, easy now. Do let me know if you are understanding this. Easy things, right? One more thing I want you guys to understand. Look here. How do you identify between A and D? Okay, A will be having a single tube. Just remember the keywords that I am giving you. If you understand these keywords, your life will be easy. Okay, so if you will be remembering this single tube and spontaneous ventilation, single tube, spontaneous, wherever you are seeing in the question, just mark Mapleson A. Okay, D will be having double tube. D will be having double tube and it will be used for controlled ventilation. Okay, D will be having double tube and it will be useful for controlled ventilation. Simple story. A patient is coming. Let me tell you very clearly what is happening. A patient is coming to you during when the patient will come to you in the hospital. The patient needs to we need to transit the patient here and there, right? So at that point of time, what we do, we use this type of circuit, this type of semi closed circuits. Okay, so what we can use, we can use this type of circuits, we can use this one, we can also use this one. Okay, if the patient is able to breathe himself, if he is spontaneously breathing, we can use McGill circuit, leg circuit, or coaxial Mapleson A. If patient is not able to breathe himself, what we can use, coaxial Mapleson D, or that is known as Bain circuit. And this is basically in real life scenario what we do. We are generally using Mapleson D. This is generally a universal circuit. In real life scenario we are using this one. Okay, Mapleson D, this is a universal circuit. Okay, this is a universal circuit. Now try to answer these questions based on the information that I am giving you. I am revising again for you. Okay, just 1 minute and you will be understanding whatever points I am telling you. Just remember this. Okay, A will be for spontaneous ventilation. अकेला होगा, मैगी खाएगा, the patient will eat Maggie, so that is McGill circuit, also known as lag circuit, and it is used for spontaneous ventilation. Answer for D, control ventilation, dependent ventilation, that is your Bain circuit, and it will be having double tube. Can you appreciate these double tubes? You will be appreciating double tubes here. Here will be single tube. Okay, and here for any choice of any kind of circuit we will be requiring in the pediatric patient, your answer would be Jackson-Rees modification, or this is Ayer's T piece. Okay, so you will be having a balloon. What he has done, he has added the balloon here, right? How you can remember these? A will be adjunct, that means the wall will be near. Okay, B will be both, means all these three things will get together. C will be corrugations absent, D will be distant, APL, the wall will be distant, E means valveless. And what the Jackson Rees has done, he has added the valve. That is the what he has done, right? So these are the circuits. Now please try to solve this question. Question number 1: a 5-year-old child is spontaneously breathing and is going under minor elective surgical procedure. Which of the following circuit can be the circuit of choice? Which is preferred in adults? We will prefer A and D in adults. Okay, if patient is spontaneously breathing, we will be using A. If patient is on controlled breathing, we will be using D. Okay, most likely we are using D type of circuit. What is the answer for this particular question? Please try to answer, guys. C. Wonderful, guys. Why A? McGill's. That is what I want to convey, and that is what examiner know that how you are going to study the question. Look here, guys, this is a pediatric patient. He has already given this spontaneously, I know, but this is a pediatric patient, and for pediatric patient the circuit of choice for spontaneous and controlled ventilation will be Jackson-Rees circuit, always and always. Okay, Jackson-Rees circuit. McGill's if the case of adults. Okay, if it is controlled, then that would be Bain circuit. Okay, understood, guys? Okay, next one, try to solve this. A 29-year-old patient presented in a surgical emergency with an acute abdomen and was posted for emergency surgery. Anesthetist decided to give him general anesthesia. Which among the Mapleson circuit is best for spontaneous ventilation in adult patient? So there are such long questions. In long question, what you need to do, you need to read the last line. Okay, which among these Mapleson circuit is best for spontaneous ventilation in adult patients? Simple question, guys. Answer will be Mapleson A. Very good. Answer will be Mapleson A. Very good, Muskan. Okay, next one. A 4-year child come to the emergency operation theater for the removal of aspirated foreign bodies with the aid of rigid bronchoscopy. Now whatever history they have given doesn't matter, you need to identify the keywords in the big questions. Okay, during the removal of the foreign body, spontaneous ventilation was maintained with a smaller size of ET tube. Which among the following is the ideal anesthetic circuit we can use for this case? This one, guys. Muskan, very good. Nandini, very nice. Mihir, very good. Now you guys are understanding. Now you will not make any mistake, because whatever history they have given, just forgot the history. Look here, 4-year-old child. So you need to read the questions very carefully, and the answer here will be C, guys. The answer here will be C1. Okay, a 25-year-old patient was posted for laparotomy due to the abdominal injury. Anesthetist decided to give him controlled anesthesia with the help. Which one will be utilizable here? Controlled. Very good. That would be Mapleson D. Okay. Then they have got you an image-based question. A 35-year-old female has undergone a radical hysterectomy. Under general anesthesia, an anesthetist tests this patient to the following breathing system. What is the name of this breathing circuit shown in the image below? I'll try to solve this question. So what you can appreciate, can you appreciate here? Two tubes are there. There are already double tubes, right? So that would be what kind of circuit? Double will be, very good, Muskan, that would be Bain circuit. Bain circuit. Okay, that is semi circuit B or Bain circuit. Okay, D is there, right? That is your controlled ventilation. Okay, so since now we are done with all the basic parts of the system. Okay, they have got you many questions in the INISET and FMG examinations, so I have get you all the questions, and now I'm really sure that you will not make the questions wrong. Even if they give you the systemic diagram of the circuit, then also you will get it correct, right? Next that we are going to discuss is about the drugs. We are done with the machines, we have seen the monitors, we are done with the circuits. Okay, short important things we are studying. We in 3 hours we cannot complete everything. I think in 45 minutes we will be completing everything. So be with me till the end of the session and you will be understanding things, right? So now we are going to see about the different kind of drugs that we are having. What are the different kind of anesthetic agents or drugs that we are having? So look here, I will be making a flow chart in which you will be seeing all the drugs here itself, right? In which you will be seeing all the things here. Are you guys understanding? Do let me know in the chat box. पल्ले पड़ रहा है नहीं पड़ रहा, समझ आ रहा है नहीं आ रहा? Do let me know in the chat box, guys. Okay. So we are having general anesthesia, we are having regional anesthesia. I think till now you must be cleared with what is general, what is regional, and what is local anesthesia, right? So I will be telling you about some drugs that we will be studying subsequently in this part, right? So we are having general anesthesia. General, we can use inhalational drug, we can use IV drugs, whatever drugs you will be studying, I will be writing here itself, right? So hard easy anesthesia, are you guys able to understand? So what are the drugs that we will be studying here? I will be making a short diagram for you so that that would be easy for you to remember. Okay, so what are the different drugs that we will be studying? In inhalational part, we will be having halo, iso, CO, and desflurane. Okay, inhalational, these four are the most important drug that we will be studying. Okay, IV drugs, we can use two things. We are having opioids, we are having non-opioids. Okay, we are having opioids, we are having non-opioids. In opioids, what are opioids? Like morphine, fentanyl, sufentanil, alfentanil, remifentanil. Okay, so we are having important one, morphine, remifentanil, okay, alfentanil, basically fentanyl type of drugs. Okay, so basically these are the opioids. Apart from that, in IV non-opioids, what are the drugs that we can use for non-opioid? These are your propofol, important, propofol, etomidate, okay, thiopentane, thiopentone, and ketamine. These are the important ones that we will be studying. Okay, propofol, etomidate, thiopentone, ketamine. In local anesthesia, in local, we will be using two types of drugs. We are having esters, we are having amides, and we are having esters. So let's write down about amides. We are having amides. What are those amides? We are having amides. Amides will be having double I. Okay, so we are having amides like lignocaine. We are using for local anesthesia. You must have seen lignocaine. Okay, lignocaine, bupivacaine, dubucaine. Okay, so we are having bupivacaine, dibucaine. Okay, second class is your esters. We are having esters. In esters, we are having what, guys? In esters, we are having cocaine. We are having procaine. We are having cocaine, procaine, benzocaine, prilocaine, benzocaine. Okay, so these drugs will be coming under the esters. Okay, then we are having the muscle relaxant. Muscle relaxant, we are having two types of muscle relaxant. First one is your depolarizing muscle relaxant. Second one is your non-depolarizing muscle relaxant. So depolarizing will be succinylcholine. Non-depolarizing will be curonium, like rocuronium, vecuronium, pipecuronium. Okay, we are having curare, atracurium, cisatracurium. Okay, atracurium, cisatracurium. Okay, so these are all the drugs that we will be studying here. Okay, so this is a short note that we have made, and we will be going subsequently line wise. We will be studying about the important points about each and every drug that has been asked in your examination and that has the probability to ask in your examination, right? So we will be starting with the halothane first. Okay, so first of all, from general inhalational, we will be starting from the halothane. Halothane, the important points about halothane is this: it is contraindicated in neurosurgery and hepatic surgery. Why, sir? Why hepatic surgery it is contraindicated? Because it will cause a disease. I think you must have known about this disease. Please try to write down. That is your autoimmune hepatitis. Halothane H4, halothane H4 hepatitis. It will be causing hepatitis. Halothane will be causing hepatitis. Second thing, it is contraindicated in neurosurgeries. What is the reason why it is contraindicated, sir? It will be increasing intracranial tension. Okay, so we will be avoiding this thing. Okay, second important thing, it is the agent of choice in respiratory surgeries. Okay, for example, it is a good bronchodilator, so we will be utilizing halothane in the cases of respiratory surgery only. Okay, so these are the important points that has been asked from halothane that you should be remembering. About isoflurane, isoflurane is a irritant. Isoflurane is a irritant, and it will be showing a phenomena that is known as coronary stain phenomena or reverse Robin Hood phenomena. Not so important, just remember this point. Okay, next one is your sevoflurane. Sevoflurane will be making a nephrotoxic compound. Okay, it will be making a nephrotoxic compound, so we will avoiding this particular thing in uh, kidney surgeries, but it will be having a sweet smell. Okay, it will be having a sweet smell, so it will become the induction agent of choice. It will become the induction agent of choice. It will become the induction agent of choice in children. Okay, it will become the induction agent of choice. It is a good bronchodilator, but not better than halothane. Okay, next one is your desflurane. Desflurane is a irritant. It will be having a pungent smell, so we cannot induce the patient by this. Okay, it can be utilized for obese patient. Okay, it is a maintenance agent of choice. It is a maintenance agent of choice. Okay, so what is the meaning of induction? You must be confused. So what is the meaning of induction? For example, the patient is coming to us. Now we need to intubate our patient. We are intubating it. Now we need to give the anesthesia to our patient. So how we can give the anesthesia? We can directly put sevoflurane. It can induce the patient. But for the cases of desflurane, we cannot directly put the desflurane because it is irritant. What will happen? It can cause laryngospasm. It irritate the larynx, right? What will happen? There will be spasm. So we cannot use desflurane as a induction agent. Okay, next one, try to answer this question. These are the questions that has been asked from this particular part. Okay, first one, what is the preferred method for inducing anesthesia through inhalational in children? Answer would be, obviously, that would be sevoflurane. It will be having sweet smell. As for sevo, will be having sweet smell. Okay, which of the following listed below can be utilized for the purpose of inducing anesthesia, sustaining it, and safely performing endotracheal intubation? Again, your answer will be sevo. Again, your answer will be sevo. We can induce the patient, we can maintain the patient, and we can safely perform all the operations, right? So that would be again sevoflurane. Okay, that would be again sevoflurane. Now try to answer this. Which of the options below is not employed for initiating anesthesia in pediatric patient? कौन सा यूज में नहीं लेंगे? We can use halothane. Yes, it is a good bronchodilator. We can use sevoflurane. Yes, we can use it. We can use nitrous oxide. It is a laughing gas. We can, along with other drugs, we can use, but we cannot use desflurane. We cannot use desflurane. Okay. Which inhalational agent is best suited for patients with compromised cardiac functioning? Okay. Now they are asking the question based on single point every time. Okay. They are asking the patient. They are asking the question based on the patient, right? Certain things they are asking again and again. Okay, so what is that you can use? Yes, we can use desflurane because it will be having a rapid onset and rapid offset. Along with that, it is CVS stable. So these are the points you should be noting. Okay, so this is a CVS stable. Desflurane is CVS stable. It will be having rapid onset, rapid offset, so we can use it for the cardiac compromised patients. Apart from that, we cannot use, right? Next one, which anesthesia agent from the options provided is known to cause toxicity to the liver? You already know the answer. That is your H4 halothane. Halothane will be causing autoimmune hepatitis. Halothane will be causing autoimmune hepatitis. Okay, so these are all the questions that I have gathered for you from the inhalational part. They are asking these simple questions. Okay, कौन सा देना है कौन सा नहीं देना है बार बार they are repeatedly asking the same questions. Okay, so let's revise again, let's recap everything. So we are having halothane. It is contraindicated for neurosurgery, agent of choice for respiratory. Isoflurane, it is a irritant, coronary steel phenomena. Sevoflurane, nephrotoxic compound. Desflurane, maintenance agent of choice, and it is a irritant we cannot use. In obese patient, we can also use it because it has a rapid onset, right, and good solubility, right. So next thing is your IV anesthetic agents. We have seen two classes here. We are having opioids, we are having non-opioids. Three slides about them and all the questions we will be doing, right? So we are having opioids, we are having non-opioids. Okay, important part are these parts. They will be having approximately 15 questions, right? So opioids will be there, non-opioids will be there. Okay, so opioids will be morphine, remifentanil, sufentanil, alfentanil. Okay, basically we are using all these drugs, for the anesthesia purpose. They are basically cardiovascular stable, very very important point. They are CVS stable, but they are causing respiratory depression. So whenever I will talk about opioids, morphine, for example, a cancer patient is also having morphine. Those patient will be having what? Respiratory depression. Okay, they will be having respiratory distress, right? So it is a CVS stable thing, but respiratory depression can be seen, right? Next one is your thiopentone, propofol, etomidate, and ketamine. They are important ones. Try to look here. First of all, we are having this injection that is a yellow color powder that you will be finding. That is your thiopentane. Thiopentane is a type of barbiturate. It is a type of barbiturate. You know, barbiturate and benzodiazepines are from the same class. They are basically a GABA mimetic drugs, right? They will be decreasing the they will be increasing the GABA, and because of GABA, what will happen? CNS will be decreased, right? So your sensations will be decreased, right? So this is a barbiturate, yellow color powder you will be finding, and you will be utilizing this particular thing for narco analysis. Can anyone tell me what is narco analysis or truth serum? So basically, I think you must have seen the movies. In movies, what will happen there? A person will come to the victim, and what they will do to the criminal, they will be injecting something, and after that, what will happen? Because of this injection, what will happen? Their cognition will down. Okay, and because of that cognition down, what will happen? The patient will be telling everything. He is not able to process what he is saying, right? Cognition is already down, so whatever is there in his mind, that thing will be coming out, and that is known as truth serum. That is used for narco analysis. We can also use scopolamine also, right? So that is the fastest one. We are having 11 to 14 second is the time, and it is contraindicated at two places. Important one, agent of choice and contraindication. These red points that I have written, they are being asked in your examination. So it is contraindicated in porphyria and bronchial asthma. They are contraindicated in porphyria and bronchial asthma, right? This one very very important, propofol. Many times the question has been asked from this is an injection, right? We can use propofol for not such a long period of time. Once we open it, we need to utilize it. Okay, you can remember the mnemonic, that is eggs, EGS. It will be having egg lecithin, it will be having glycerol, it will be having, as for soybean, it will be having three things: egg lecithin, glycerol, and soybean. So it will be a painful injection, right? It will be milky white in color. What is the color consistency? That would be milky white, and it will be agent of choice in multiple things. Daycare surgery, agent of choice. Liver and kidney damage, agent of choice. Neurosurgery, agent of choice. It can be used as antiemetic as well, because after this there is decreased chances of vomiting, right? And it can be agent of choice in the patients with malignant hyperthermia that we have already done, right? That question we have already completed, right? So these are the important points about this. But the contraindication that you always need to remember is shock. What is the contraindication? That is shock. In shock patient, we cannot use propofol. Otherwise, propofol is a very safe drug that we utilize in most of the cases of daycare surgery. What is daycare surgery? A patient is coming to you in the morning, he is getting admitted, he is having some kind of operation. In the evening or in the next morning, we will be discharging the patient. That is the daycare surgery, and we are utilizing propofol for that, right? Next one is your etomidate. Remember guys about etomidate, it is a CVS stable drug. It is milky white in color. Amidate you can remember. And contraindication is adrenal suppression. It will be suppressing the adrenal gland. Okay. Lastly, we are having ketamine. Ketamine will be causing, it is an NMDA blocker. Okay. It will be a best bronchodilator among this group, non-opiates. It is a best bronchodilator. It is a sympathomimetic drug. Sympathomimetic means what? It will be working like sympathetic nervous system, like epinephrine, norepinephrine, dopamine. Okay, sympathomimetic है तो क्या होगा? It is the agent of choice in shock, because the drug of choice for shock will be your noraddopa, right? Dopamine, noradrenaline, adrenaline, right? So all these things will be sympathomimetic, so we can utilize this particular drug in those cases. Okay, apart from that, it can be used for bronchial asthma, analgesia, painkiller, and it will be causing a special thing that is known as dissociative anesthesia. That means when you are operating on the patient, he will be awake, he will be watching all those things, but he cannot feel the pain and all those sensations. Okay, and it will be having after the completion of surgery, he will be having some kind of delirium or hallucinations can happen, right? What are the contraindications? Hypertension, epilepsy, and glaucoma are the three contraindications of this. Okay, hypertension, epilepsy, and glaucoma. So let's revise what we have done. We have done IV anesthetic agents, two parts: opioids, non-opioids. Opioids, just remember, it is CVS stable respiratory depression. Okay, non-opioids: thiopentane, propofol, etomidate, ketamine. Thiopentone, propofol, etomidate, ketamine. Just look at this particular slide. Many questions has been asked from this particular slide, right? So please try to answer those questions. Which of the following intravenous anesthetic agent does not result in myocardial depression? Which one is myocardial safe, CVS stable? Try to answer which one is CVS stable. Out of what we have studied today, which one is CVS stable? Yes, that would be. Try to answer, guys. Waiting. Yes, that would be etomidate, amidate, right? We have seen amidate is the CVS stable. Second, which one of the following agent does not cause pain when injected? All of these are liquidy materials. Okay, yellow powder, milky white, and this is also milky white. So all of them will be causing pain. This one is its consistency is good, so this one will not cause pain. So ketamine is the one which does not cause pain. Very nice, very good, Nandini, Muskan, Mihir. Okay, so that is your ketamine. Okay, that is your ketamine. Which of the following is an absolute contraindication to the more or to the use of morphine? Absolute contraindication. That is the question they have asked recently, guys. Okay, so absolute contraindication here will be head injury, because it will be causing intracranial pressure. It will be increasing a lot of intracranial pressure. Yes, bronchial asthma and emphysema are contraindication, but they are not absolute contraindication. Okay, they are not coming in the absolute contraindication. Okay, we can manage that. For a patient with cardiac disease, which of the following induction agent would be most suitable option? This is a repeat question. The answer will be etomidate. Okay, wonderful, guys. Okay, now next, for daycare anesthesia, what is the preferred intravenous induction agent for daycare surgery, guys? What you will be using? Yes, very good. We will be using propofol. We will be using propofol because it don't have any residual effect. Don't have any residual effect. Okay, it will be going out exactly, right? Next one is your which inducing agent is most likely accountable for the patient's hallucination and vivid dreams during the recuperation phase following anesthesia. I've told you dissociative anesthesia is done by ketamine. Okay, so here the answer will be ketamine. Here the answer will be ketamine, guys. Okay, here the answer will be ketamine. Okay, so I think you can do such type of question. If they ask you such type of question in your examination, I think you will be able to do this type of questions, right? Next one is your local anesthesia. Next one is your local anesthesia. Okay, so what we have seen the let's recap whatever we have done. Let's recap that. Okay, so we have seen the general. In general part, we have seen the inhalational agents, we have seen the IV agents. And we are already done with the inhalational agents. And now we are already done with the opioids, non-opioids. Important one, propofol, etomidate. Multiple times they have asked the question, right? Thiopentone, ketamine, which one is CVS stable, which one is not stable, which one daycare surgery, all those questions, right? Now in the regional we will be studying about the local anesthesia. Okay, in the regional part we will be looking at the local anesthesia. Okay, so how does this local anesthesia will work? They will stop the transmission of impulse locally by blocking the sodium channel. Try to understand what is happening. This is your neuron will be having action potential which is running, and the action potential generated is due to sodium. There's a little bit of physiology. Okay, so because of sodium, action potential is generated, and because of that impulses are traveling in the forward direction. Now what is happening? They are blocking the transmission of impulses locally by blocking the active sodium channels. They are blocking what type of sodium channel? They are blocking the active or open sodium channels. Okay, so what will happen? There will be no sodium going inside. No sodium going inside means no generation of impulse, no transmission of impulse, nothing will be going forward. Okay, so they will be working on the open sodium channels, and we will try to mix it with the adrenaline will be working on four receptors. Pharmacology, try to answer. We are having alpha 1, we are having a beta receptor, beta 1, beta 2, alpha 1, alpha 2. So it will be adrenaline, A for adrenaline, working on all the receptors, right? So it will be mixed with adrenaline will cause what? Vasoconstriction. So that this drug, whatever local drug that we are putting, it will not go here and there via systemic circulation, right? So to prevent the mixing of drug in the systemic circulation, what we are doing, we are mixing it with the adrenaline. Okay, I have told you we are having two classes. One is ester, another one is amide. Just remember, in amide we are having I, so these drugs will be having double I. These drugs will be having double I. Okay, so we are having lignocaine, we are having prilocaine, we are having bupivacaine, we are having dibucaine. So all of them will be having double I. Amides will be having double I. Esters will be having single I. They are cocaine, procaine, chlorprocaine. Okay, one more important thing about them, all the mites are getting their metabolism via liver, that is hepatic metabolism. Okay, whereas esters will be metabolized by pseudocholinesterase enzyme. Okay, pseudocholinesterase enzyme, right? But there is an exception, that is cocaine, and exceptions are generally asked. Cocaine is undergoing what kind of metabolism? That is again hepatic metabolism. Cocaine is a type of ester, but it will be undergoing what kind of metabolism? That is hepatic metabolism. Okay, that is hepatic metabolism. Now some important points about important questions that has been asked about these. Okay, esters and amides we have differentiated. Now some important questions. First one is your cocaine. Cocaine will be causing vasoconstriction. You must have seen, you must have studied in other subjects also. Those people who are on cocaine, what will happen? Because of snorting of the cocaine, what will happen? There will be septal perforation. Why? Because it will be causing hypertension, it will be causing vasoconstriction. Whenever there is a vessel constricted, what will happen? The pressure will be more on the vessel, that is known as increase in BP, also known as hypertension. So this patient will be having vasoconstriction leading to nasal septal perforations also. Okay, shortest acting one, which one is the shortest acting? That is your chlorprocaine. Shortest acting will be chlorprocaine. Shortest acting will be chlorprocaine, and the longest acting will be dibucaine, guys. Dibucaine. Longest acting will be dibucaine, and safest, whatever you have heard more, will be the safest one. So which one you have heard more? That is your lignocaine. Lignocaine is the safest one, and the most cardiotoxic one will be most cardiotoxic. That is your bupivacaine. That is your bupivacaine. Okay, so you will be getting a lot of questions on bupivacaine. There will be a history given. On the history, they will be giving some kind of a local anesthesia drug, and bupivacaine will be the answer, and the patient will be having some kind of severe symptoms, right? So what are the complications? The complications that are happened due to this local anesthesia, they are known as last means local anesthesia systemic toxicity. When this local anesthesia is going into systemic circulation, that is your body, what will happen? You will be having certain symptoms in your, when it is going to your CNS, it will be causing tinnitus, it will be causing perioral numbness. Apart from that, when it is going to CVS, what will happen? You will be having arrhythmias and cardiac arrest. So in the question you will be finding these symptoms. Okay, in the question, what is important for you to understand this, how to utilize this information? Okay, you will be finding for the symptoms. So you will be looking for arrhythmias, you will be looking for cardiac arrest. Okay, how you will treat this particular situation? 20%. This is the question, multiple times repeat. 20% intralipid emulsion. First of all, whatever drug you are injecting, you need to stop that. Second thing, what you need to give 20% intralipid emulsion. Okay, that is the drug of choice, that is the treatment of choice for this particular thing, right? How we can utilize this local anesthesia? In the topical, we are having a eutectic mixture of local anesthesia. That is the question asked multiple times. Okay, so what is that amla? Amla is a type of a patch that we are having. Look here, we are having this type of patch. They are known as amla patch. Okay, EMLA, that is eutectic mixture of local anesthesia. What will happen? Two things will be there. First one is your lignocaine, second one is your prilocaine. They are added in the ratio of 1:1, that is 2.5 to 2.5%. Okay, both of them will be 2.5%. Okay, next thing, infiltration. What is the meaning of topical? I've told you, we are adding something topically. How we are utilizing it? For example, I need to do cannulation to some patient. Okay, and the patient is always crying for cannulation. What I can do, uh, I can put amla, and then what will happen? There will be no pain sensation, and I can put my catheter, right? So that is how we can utilize this information. Second is your infiltration anesthesia. So in infiltration anesthesia, we are putting the drugs around the nerve fiber. Okay, for example, I need to do tooth extraction. What I will be doing, I will be putting certain injection, and I will be putting the drugs around the area, right? That would be giving me a good block, right? So what will happen? We can use this infiltration type of anesthesia. This is also known as caudal anesthesia. Okay, we will inject the drug around the, oh sorry, we can also give in caudal anesthesia. Also caudal anesthesia, we can inject the drug around the terminal phylum. Okay, around the terminal phylum we are injecting the drug. That would be again giving a type of infiltration anesthesia. Okay, next one is your regional anesthesia, guys. Next one is your regional anesthesia, very very important. We are having regional, we are having central neuraxial blockade, we are having central neuraxial blockade. Two important thing, one is spinal, another one is epidural. Important point is spinal we are utilizing for short duration, epidural we are utilizing for long duration. First question that they ask you is this, and second question that they ask you is about the needle. Okay, they will be giving you the image of this particular needle, and they will be asking you how to identify. So first of all, see if you are seeing some markings. Very important question that they ask you. If you are seeing some marking and you are seeing some wings, if marking is present and wing is present, that is your epidural anesthesia. Epidural we are using for a long period of time, that is 7 to 8 hours. Okay, when you are seeing no no wings, no marking, no marking, no wings, this is a type of spinal anesthesia. This is the type of spinal anesthesia. Okay, we are having different kind of needles. We are having dura cutting needles, Quinque, Whitcare, Proti. Okay, these are your Quinque, this is your Whitcare, this is your Sproti. Okay, but all of them are spinal needle, and this one is the epidural needle. Okay, what is the route? They have asked multiple times this question. This is the expected question, guys. Please try to focus on this. Okay, this is the most important question that they ask you. So what is the route? How we are going inside? So we are going from the posterior side, we are going through skin on the back side. Then the first thing that is coming is your subcutaneous fascia. Okay, then coming the supraspinatus ligament, and then coming the interspinous ligament. First supraspinatus ligament, that is above, then intraspinous ligaments, and then coming the ligamentum flavum, and then these your layers, that is your depth, durameter, arachnoid and subarachnoid. Okay, and then there will be pyometer. Okay, so where we are giving the drug, that is important. Okay, this is the sequence you have to remember. How you will remember? Outermost layer will be skin, then subcutaneous fascia you will be finding everywhere. Okay, then supraspinatus ligament. Can you appreciate this supraspinatus ligament? Then there is intraspinous. Intraspinous means, supraspinous means above the spine, intraspinous means between the spine, right? You can remember like that. So supraspinous will be above the spine, intraspinous will be between the spine, and then there will be ligamentum flavum, and then your layers pyometer, arachnoid, and your durameter. Okay, so durameter, arachnoid, and subarachnoid. Whenever you are injecting your drug in epidural space, Above the dura will be a space that is known as epidural space. Okay, whenever you are putting your drug in epidural space, that is known as epidural anesthesia. Whenever you are putting your drug in below subarachnoid space, that is in the CSF, that is known as spinal anesthesia. Okay, so that is the basic differentiation. Spinal anesthesia, for as for spinal, it is for the short period. Epidural में L आता है, that is for the long time, it is for the long period. Okay, for long period we can give analgesia also along with that. Okay, so now we understand two important questions from this. First one was on the needles and second one is on the time and this part. Okay, this is the important part. Now what are the complications, what are the most important complications that can happen during this? The most common complication will be hypotension. How you are going to treat that hypotension? You know, alpha 1 agonist you can give, that would be causing vasoconstriction, and the drug name is phenylephrine. Okay, bradycardia. For bradycardia, the drug of choice is always like atropine. Atropine is the drug of choice for bradycardia with AV block also. Okay, and urinary retention, you can also give neostigmine, that you have already studied in pharmacology, right? What are the contraindication of spinal and epidural anesthesia? What are the contraindication? If there is any kind of infection, increased intracranial tension, or some kind of cardiac disease, that is the contraindication. Okay, for labor analgesia, during labor, you know, we need to put the patient on anesthesia for long period of time. Okay, we need to give analgesia also. Analgesia means we need to decrease the pain sensation also. So we are using this epidural catheter. We are putting the catheter above the dura. We are putting the catheter, and then we can give the local anesthesia. Along with that, we can give opioids. I have told you opioids are mainly using for analgesia purpose. Okay, we can use morphine, we can use alfentanil, sufentanil, any drugs. Okay, and epidural catheter is the gold standard for labor analgesia. Okay, important point. What is the needle shown in the picture below? Now you can easily identify. Look here and please try to answer this question. This is the exact question that has been asked in your examination. What is the needle shown in the picture? Try to answer, guys. What is the local anesthesia among the following leads to an increase in blood pressure? Which of them will be increasing the blood pressure? Try to answer this one also. So here you are finding some markings. Along with that, you are finding the wings. Very good, Mushkan. Very good, Karishma, Mihir. Yes, so that would be your two-His needle. That would be your two-His needle. Look here, guys, what I have told you. Look here. If you are seeing these markings and wings, that is your two-His needle. Okay, this one is your dura, Quincke, Whitcare, other needles. They will not be having markings, they will not be having wings. Okay, second question. What is the local anesthesia among the following leads to increase in blood pressure? I have already told you cocaine will be increasing vasoconstriction, leading to increase in BP. Cocaine will be leading to vasoconstriction, leading to increase in BP. And this is the most famous question they are asking again and again. Try to answer this one. A patient presented with headache, vomiting, fever, meningitis was suspected. The patient is having meningitis. While performing the lumbar puncture, which is the last structure you will pierce just before entering the lumbar system. So you already know what we have seen. Last structure will be arachnoid. Okay, last structure will be arachnoid, and then there will be spinal CSF, then there will be cerebrospinal fluid. Okay, next question. What would be the most appropriate approach to managing a young male patient who received regional broke using 0.25% bupivacaine? First thing, you already know bupivacaine is a cardiotoxic drug. For a minor surgical procedure but experience sudden unresponsiveness and unrecordable pulse, no pulse, no oxygen, what you will be giving? CPR, cardiopulmonary resuscitations, right? You will be checking for pulse. If there is no pulse, that means no circulation. You will be checking for breathing. There is no breathing, then you will be going for CPR, right? So you will be giving CPR, and the drug of choice here is 20% intralipid, and the diagnosis here is local anesthesia systemic toxicity. Okay, last will be there. Okay, next question. How do local anesthetic exert their mechanism of action? We have already seen we are having nodes of Ranvier in the exon. Nodes of Ranvier are there, and it will be having maximum sodium channel, and we are blocking those sodium channels. So impulse transmission will be stopped, and if the impulse transmission will be stopped, what will happen? There will be no sensations, there will be no movement, right? So answer will be blocking the sodium channels, right? What is the likely diagnosis for a patient who received 20% intralipid injection during resuscitation? Resuscitation. What is your diagnosis, guys? Very good. Diagnosis will be last. Okay, they have asked this particular question multiple times. Okay, during epidural anesthesia, which of the following structures are not penetrated? Epidural means we are giving the drug above the dura. We are giving the drug above the dura. That means what is the drug that we are not, what is the layer that we are not piercing? That is obviously dura mater. That is obviously dura mater. Okay, so how we are going? We are going through skin, subcutaneous fascia, then supraspinous ligament, then interspinous ligament, ligamentum flavum, then there will be dura mater. Okay, so before going below dura mater, we are giving the epidural drugs. Okay, so we are not puncturing what? We are puncturing supraspinous, intraspinous, and ligamentum flavum, but not dura mater. So answer here will be dura mater. Okay, which type of anesthesia is most suitable for preeclampsia? Right now I have told you for labor analgesia. Labor analgesia, which one is the best? For labor analgesia, which one is the best? That is your epidural. Epidural. Okay, you know what happens in preeclampsia? There will be hypertension, there will be multiple things. So there is a risk of airway edema. There is a risk of airway edema. So we cannot use other type of anesthesia. We cannot utilize the airway of the patient. We cannot use GA also, right? So because of difficult intubation or multiple things can happen, right? So best approach will be epidural anesthesia. Epidural anesthesia, we will go to the dura, we will feel like loss of resistance, we will put the catheter. Now what will happen? How much drug we need to inject? We can inject. Okay, even after giving the drug, what we can do, we can give the analgesia to the patient. After anesthesia, we can also give analgesia to the patient also, right? So that would be very beneficial for us. How do local anesthesia works? Again, same question. Your answer would be, it will be blocking what kind of channels, guys? It will be blocking potassium or sodium channels. Okay, this was the question back in 2021. It was there. So, what is the preferred anesthesia for dental surgery performed in a daycare setting? Okay, so your answer would be infiltration, guys. Infiltration, I have told you what we are doing. We need to extract the tooth. I cannot put the patient into general anesthesia or something like that. What I will be giving, I will be putting some drugs all around the corners, and what will happen, all the nerves will be desensitized, right? They will be anesthesia, right? In epidural anesthesia, which of the following layers is least likely to be punctured during the procedure? Simple answer, simple question, guys. Here your answer would be arachnoid. We are not going that deep. Okay, same type of question that they have given, right? Next one is your muscle relaxants. Next topic, next topic is your muscle relaxants. Okay, so what is there in the muscle relaxant? We are having, what we are doing basically in anesthesia, what will happen? We need to produce loss of consciousness, we need to give analgesia to the patient, we need to give amnesia to the patient, we need to block the sensation of the patient. So we need to give muscle block, we need to give muscle relaxants. Okay, we are having two types of muscle relaxant. Before that, try to understand how they are working. Muscle has a specific property. That means when you are giving constant stimulus, for example, I'm coming to you on a constant interval and telling you to study, what will happen? You will study, right? So if something is depolarizing means what? We are constantly stimulating, a cell. What will happen? It will not work, right? So muscle has a property, it will be working on a adequate stimulus. It will be working on a adequate stimulus. That means when you are giving a lot of stimulus, what will happen? It won't work. Too much stimulus, it won't work. Too less stimulus, it won't work, right? So we are giving depolarizing and non-depolarizing types of drugs, right? Depolarizing, generally from the nerve we are getting acetylcholine. So it is just like acetylcholine, that is your succinylcholine. It is a short acting muscle relaxant. It is contraindicated in nerve muscle injury. It can cause hyperthermia, bradycardia, fast metabolism. What are the uses? It is very fast, so we can use it for rapid sequence induction. We can use for ECT also. There is update, guys. Right now for ECT we are using methotrexate. Okay, for ECT we are using methotrexate, but we can use it for difficult airway also. Okay, drug of choice will be methotrexate. It is updated now. Okay, apart from that, non-depolarizing, we are having aminosteroids, we are having benzyl isoquinolones. Okay, we are having aminosteroids, we are having benzyl isoquinolones. Okay, what you need to remember, amino will be having no. Okay, so we are having no wali dawaiya. What are those? Pancuronium, we are having rocuronium, we are having rapacuronium, vacuronium. So all those curonium will be there, no will be there. Okay, so no means what? It will not cause histamine release. They will be CVS stable and they will be used in liver and kidney disease also. Okay, and they are agent of choice in bronchial asthma. Second one, benzyl isoquinolones. They will be releasing what? Histamine. Histamine, basic function of histamine will be, try to answer guys, what is the basic function of histamine? What histamine will do to your body? Examples will be atracurium, cisatracurium, and mevacurium. They will be releasing histamine, and the basic function of histamine will be, it will be causing vasodilation and bronchoconstriction. Vasodilation, that means when your vessels get dilated, what will happen? You will be having red, right? Whenever there is a release of histamine, whenever there is release of some mediator, what will happen? There will be itching, and because itching is because of vasodilation. Okay, and histamine can cause bronchoconstriction also. Okay, most potent bronchoconstrictor, your answer will be not histamine, that is your leukotrienes, guys. Okay, leukotrienes. Asthma is always related with leukotrienes. Okay, so that is your histamine. Okay, non-depolarizing one. So you just need to remember, no means pancuronium, vacuronium, rocuronium. These are the examples. Okay, now cisatracurium and atracurium. The important thing about that cisatracurium and atracurium, they will be undergoing a specific elimination that is known as Hoffman's elimination. What is that, sir? Hoffman's elimination क्या होता है? These drugs will be inactivating itself without any kind of utilization of any organ, right? They will be undergoing spontaneous, they will be undergoing spontaneous metabolism. Okay, that means they do not require liver or kidney for their metabolism. Okay, so they are undergoing Hoffman's elimination. So what is the utilization, sir? They are safe in liver and kidney disease. So when the patient is having kidney or liver disease, I can use this drugs for muscle relaxation. Okay, after giving muscle relaxation, I need these patients to get reverse, right? How I can reverse those patients? I can give neostigmine along with atropine. Okay, they are the indirect agents. Basically what we are doing, we are blocking everything. We are blocking acid, we are giving acetylcholine. Okay, acetylcholine will do what? Acetylcholine is a function of like parasympathetic nervous system, right? So what we are doing, we are just putting the opposite effect. Okay, so we can use neostigmine plus atropine as an indirect blocker. We are having direct drugs. These are your Sugama Dex and Calabidione. Okay, these are your direct drugs. We are Sugama Dex we will be using for rocuronium and vacuronium. For all non-depolarizing muscle relaxant we can use Calabidione. Okay, these are the drugs we need to remember. Okay, now please try to answer these questions. Which is the fastest clinically available non-depolarizing neuromuscular blocker? Which one is that? Please try to answer. Which one is the fastest clinically available non-depolarizing? First of all, they are asking about depolarizing, non-depolarizing. So they are asking about non-depolarizing, right? Non-depolarizing one. So your answer would be guys. Yes, your answer would be rocuronium. Just remember, it is fast as rocket. Rocuronium is fast as rocket. Okay, we can use this drug for modified RSI also, rapid sequence of induction. We can also use it. It is like it will take approximately 1 to 2 minutes. Okay, it can take 1 to 2 minutes. In the near future, it will be replacing your succinylcholine also. Okay, because with succinylcholine we are having other things also. Okay, so try to answer this. This one we have already seen. This is your ulnar nerve and this is your neuromuscular monitoring, and we are giving the most common response that we are using here is 10 of 4 response. Okay, we are giving 4 stimulus and then we are checking the response whether the muscle is adequately paralyzed or not. Okay, last slide guys, try to answer. A patient who received a supraclavicular brachial plexus block with 0.5% bupivacaine develops hypotension and arrhythmia. What is the first line treatment? You already know that. Hypotension, arrhythmia, same symptoms. Arrhythmia will be there, hypotension will be there, most common symptoms. The answer will be 20% intralipid infusion. I really hope if 5 questions are coming from this anesthesia, I really hope you guys will be able to solve all of them, right? I have incorporated everything. Okay, a patient with high is a patient with high bilirubin levels and high serum creatinine is planned for a surgery. What is the muscle relaxant of choice in this patient? Please try to answer. Look here, guys. What is happening? Look here, guys. I'm answering. Okay. What is happening here? High serum creatinine is given. High bilirubin is given. So, high serum creatinine and bilirubin is already given. That means serum creatinine is a marker for serum creatinine is the marker for. No, Dinesh, vacuronium is not the shortest. Mevacurium is the shortest one. Mevacurium is the shortest one. Okay. So here, you guys must be finding atracurium, cisatracurium in the option, but this time they have not given these drugs in the option. So answer here will be mevacurium. This one is the shortest, I think. Shortest one is your mevacurium. Okay, mevacurium. Now what I have done, you guys have to be more interactive with me. Please try to answer fast. Okay, I have incorporated all the important questions that has been asked in a single slide. Okay, so we will be discussing them. So I will be asking, what is the agent of choice in heart disease? In heart disease patient, IV, what we have seen, etomidate, thiopentone. Okay, we have seen two things in IV. We have seen two things. One is your opioids, and second thing we have seen the non-opioids. In non-opioids we are having thiopentone, we are having etomidate, we are having propofol, we are having ketamine. Okay, so agent of choice will be etomidate. Agent of choice here will be etomidate. For asthma, the agent of choice will be ketamine. Remember guys, ketamine is a good bronchodilator. It is a good bronchodilator. For shock patient, what is the drug of choice? We are using shock patient guys, ketamine. Remember I have told you ketamine is a sympathomimetic drug. It will be acting like epinephrine, norepinephrine, right? So answer here will be ketamine. What we cannot use? We cannot use propofol. Propofol is the contraindication for shock, right? Daycare surgery, definitely the answer of choice will be propofol. Okay, neurosurgery, always we can go for propofol. Okay, now let's talk about the inhalational agents. What inhalational agents we have seen? Halo, iso, sevo and des. Okay, for heart disease the agent of choice will be des and then iso. Des because it is rapid, it has faster onset and faster release also, right? So it can be CVS stable also, so we can use desflurane. For asthma I have told you halothane is a good bronchodilator, and second best will be sevoflurane. Sevoflurane we can use for induction, we can use for maintenance also in children also. It is the agent of choice, right? Next thing is your shock. For shock patient we can use desflurane because it is fast acting, right? For daycare surgery we can use desflurane. For neurosurgery we can use isoflurane. For neurosurgery we can use isoflurane. Let's talk about the muscle relaxants. Okay, for heart disease the best one would be vecuronium. For asthma the best would be all kind of coroniums we can use. Okay, for shock we are having pancuronium. For daycare surgery mevacurium because it is the shortest one. Okay, neurosurgery, all of them are good enough. Okay, we can use any of them. Okay, so these are all the important agent of choice points for your examination that has been asked in your previous year questions. I have clubbed together, right? Next thing, important point, last point, that is your oxygen delivery system. Nowadays questions are being asked from this oxygen delivery system. We are having two types of devices. We are having low flow devices and we are having high flow devices. Okay, low flow devices and high flow devices. In low flow devices we are having nasal cannula, we are having simple face mask, we are having face mask with reservoir. In high flow we are having venturi, nebulizer, high flow nasal cannula HFNC, and we are having ambu bag. Okay, first of all try to understand what is FiO2. Do you know the meaning of FiO2? The meaning of FiO2 is nothing but simple. For example, this is the environment. I am sitting in my room. Okay, in my room what is happening? There is environment, there is oxygen all around, there is the oxygen. How much is the oxygen in the environment? That is your 21%, right? 21% is the oxygen. So whatever air I am inhaling, out of that only 21% would be oxygen, right? So how much amount of air is going into my lungs? 21% will be oxygen, right? So this is the fraction of, this is basically nothing but fraction of inhaled oxygen. Okay, this is the fraction of inhaled oxygen. So from environment, 21% oxygen will be going into my lung, and I can write it into 0.21. One thing that they ask you is FiO2. Now you understand the meaning of FiO2. What is FiO2? Okay, second thing they ask you about the flow meters. Remember guys, I have told you about flow meters. In intermediate system there will be pipes will be coming and these pipes will be connecting here, right? And there will be some kind of humidifier. Okay, and here there is a flow that is known as flow control. Okay, nothing fancy, right? So this is your flow meter. You will be finding these in hospital. They will be having some amount of water. What it will be doing, it will be humidifying the gas, right? So these two things they will be asking. Till now, oxygen delivery, two things: low flow devices, high flow devices. Low flow will be nasal cannula, simple face mask with reservoir. Second one, venturi, nebulizer, HFNC, and ambu bag. Okay, now look here, we are having certain types of devices. Okay, first one is your nasal cannula, second one is your simple face mask and face mask with reservoir. Two things they will ask you. First is FiO2. Now you understand it can give 24% to 45% of oxygen. It can give out of all the air which is given via this nasal cannula, 24 to 45% of oxygen can be given, right? And what is the flow rate? Flow rate will be 2 to 6 liter. Flow rate will be 2 to 6 liter. This is used for mild hypoxemia. Okay, this is we can use for mild hypoxemia. You can see these are your nasal cannula or nasal prongs, right? Next one is your Hudson mask. This is your Hudson mask. The flow rate will be 6 to 10 liters and the FiO2 that you can get is maximum 60%, 35 to 60%. This is your simple face mask. Okay, you can appreciate that. Okay, next one is your rebreathable and non-rebreathable mask. This was the exact question that they have given you. Here the flow rate will be again 6 to 10, rebreathable and non-rebreathable. We are having two types of mask. Okay, the flow rate will be 6 to 10 and FiO2 will be again 60 to 70%. Okay, and RBM flow rate 10 to 15, flow rate will be increased. Okay, because of that mask like thing, non-rebreathable, because of that flow rate will be increased and FiO2 will be 60 to 80%. Okay, 60 to 80% will be FiO2. You have to remember this as it is. Okay, venturi they have already given the PYQs. This was the image. Okay, they are the different size of walls we are having. Okay, and they can give, we can put the valve and we can fix the FiO2 also. They are basically a high flow device. Okay, whenever you see this type of colorful type of picture, just go for venturi mask. Okay, nebulizer, you must have seen nebulizer. You will be putting some drugs inside it, that will be making the drug in the breathable form. Okay, this one image they have given you HFNC, high flow nasal cannula. Okay, uh, this can give up to 60 liters per minute and the FiO2 can be 0.21 to 1. That means it can even give 100% of oxygen, and because of these humidifier will be attached here. Okay, so what will happen, it will automatically heat and humidify the gases. Okay, Yes, they are a little confusing, I know, but you have to remember as it is, because you have to remember four only. Okay, this nebulizer is already gone. Nasal cannula, simple mask, and mask with reservoir. Hudson, you already know, right? Venturi, you will be finding these type of structures. Okay, these type of small valves you can find. HFNC is already justified. It will be having humidifier. It will be having big structure. Along with that, you will be having high flow device. It is right. And lastly, we are having bag and valve. You must be seeing this is your bag and valve. It is easy to understand. It can give 0.21 to 100 when we are connecting. When it will be giving 100, generally we are putting like that. Okay, we are using without the reservoir bag. When we are adding the connection via a cylinder, what will happen, it can even directly give the 100% of oxygen. Okay, so these are the basic oxygen devices that you should be remembering. Okay, now try to answer this question. Which device in conventional oxygen therapy will provide the highest FiO2? Highest FiO2, simple guys, highest will be given by high flow nasal cannula. Okay, it will be giving humidified and heated gas also. Humidified and heated air. Which of the following airway device help to maintain FiO2 of 24 to 60%? Now, if they are giving 24 to 60, you must be understanding what does this mean? That the patient can have 24 to 60% of oxygen out of every gas that is given. He can have 24 to 60% of oxygen, and based on the different kind of valves we are having, the answer would be Venturi, guys. In Venturi, we will be having different sizes of valves. Remember, guys, these valves I have told you, these are the valves. They are having different size. Okay, it can range from 21 to above also. Okay, so these are the valves. No need to go into much details, but here the answer would be Venturi mask. Okay, you need to go for full lectures. Okay, identify the equipment shown in the image below. Try to identify. What is that? This is your high flow nasal cannula. This is your high flow nasal cannula. Okay, identify the mask given in image used for the patient with COVID-19 infection. COVID-19 infection, what is the mask that we are using? This is your non-rebreathing mask. Okay, this is your non-rebreathing mask, and that was the question that has been asked in your examination. Okay, that was the question. Next, we are having different kind of fluids. We are having basically two types of fluids. One is crystalloid, another one is colloid. For example, when you go to hospital, you will be finding the bottles of NS or RL. You will be finding some kind of labels, right? On the labels, for example, it is written 0.9% sodium saline. What does that mean? That means that the osmolality of the particular solution is similar to your blood plasma, right? That is similar to your blood plasma. We are having isotonic, hypertonic salines also. Okay, so basically we are having two types of solution. One is crystalloid, another one is colloid. This one is your normosol. The images they have given you and asked you whether it is a crystalloid or colloid. So just for the remembering purpose, we are having plasma light, and in colloid we are having dextran, we are having albumin. Can anyone tell me what is the function of albumin? What is the function of albumin? In crystalloid, we are having RL, we are having NS, that is normal saline, we are having ringer lactate also. Okay, so how we are going to utilize this particular set of information? We are having crystalloid, we are having colloid. Okay, so answer till then, try to answer me. Okay, so what we are going to do, for example, you are going somewhere, you are going outside, and you know what happens, there is a road traffic accident. There is a road traffic accident, and there is a blood loss. There is blood loss of a patient, and he lost 2 liters of blood. Let's say he lost 2 liters of blood. So how you can compensate that? How much amount of crystalloid you need to give, or how much amount of colloid you need to give? So for example, he has lost 2 liter of blood. What you will be giving? You will be giving three bottles. Okay, 3 liter for 1 liter of blood. Okay, 3 liter of crystalloid solution for 1 liter of blood. So that would be going in the ratio of 3:1. For example, you lost 1 liter blood, you need 3 bottle of NS or RL. Okay, So you need 3 bottle of NS, RL, plasma light, anything. Okay. Yes, very good. That is the maintenance of osmotic and oncotic pressure, whatever you call it. Okay. Second one is your colloid. Colloid, if you are if they have lost 1 liter of blood, you can give 1 liter of blood itself, right? 1 liter of starch or dextran can also help with that, right? So colloid and crystalloid will be having this particular difference. Okay. Now try to answer this question. A 56 years old male patient was brought unconscious by his friend to the emergency department and reported chest pain about an hour ago. Along the way, he lost consciousness. He is a known case of ischemic heart disease, diabetes mellitus. He has a feature of consistent cardiac arrest. Okay, first of all, tell me what is the drug of choice for cardiac arrest and which would be useful in this particular situation. What will happen in the cardiac arrest? Cardiac arrest में क्या होगा? Cardiac arrest, heart failure, multiple things are there. Can anyone tell me the difference between cardiac arrest, heart failure, cardiogenic shock, okay, myocardial infarction? All these things are different or same? Cardiac arrest means what? Heart has stopped working. Heart has stopped working. If heart is not working, what we need to do? We need to give adrenaline. Adrenaline. Okay, because adrenaline will be working on alpha 1, alpha 2, beta 1, beta 2. Okay, alpha 1 will be causing vasoconstriction, alpha 2 not so much function, beta 1 will be causing vasoconstriction, increasing your heart rate, as a node it will be increasing your contractility, beta 2 will be causing bronchodilation. And here we are having the patient of cardiac arrest. Cardiac arrest means what? The drug of choice will be adrenaline. Okay, drug of choice will be adrenaline. Here the best option will be normal saline, because it will be causing, because when we are giving saline to the patient, what will happen? The cardiac load will increase. Okay, the blood will increase in the body, and what will happen? The patient can regain. Okay, next one, try to answer this. A 30-year-old male patient present to emergency department with physical examination, findings suggestive of severe dehydration. He is commenced on intravenous fluid at the rate of 1800 ml per hour. What cannula type would you like to rehydrate in this patient? Try to answer this question. What is the color of cannula you will be using here? The most wide bore cannula you will be using here, and that would be your gray color cannula. Okay, that would be your gray color cannula. Okay, try to look here. We are having this mnemonic, you must have remember this. We are having 14 gauge. The more the gauge means, the more the smaller the gauge, the more the size. Okay, so orange will be having big diameter, that means it will be giving 250 to 300 ml of blood or whatever we are giving. Okay, so that will be giving, the flow rate will be 250 to 300 ml. How you can remember? You can remember with the help of this mnemonic, you can remember with the help of this mnemonic also. Okay, what is that? Oh great God, please bless your people. Okay, oh great God, please bless your people. That means O for orange color, G for gray color, next G for green color, please for pink, bless for blue, your for yellow, and people for uh, purple. And they are in the gap of 2. So this one is 14 gauge, gray will be 16, green will be 18, okay, pink will be 20, blue will be 22, yellow will be 24, and this purple will be 26. Okay, so based on the size, what we can do, we can use it for the different type of patient. For example, this purple we are using for premature patients or old patients. Okay, because it will be having a very narrow area and narrow diameter, and because of that only 10 to 15 ml thing can drugs can come out. Okay, we are putting NS, so 10 to 15 ml can come out. Okay, it will be having a very narrow area. Okay, second one is your pediatric. For pediatric patients we are using yellow and blue. For adult patient we are using pink and green in generally. Okay, and for trauma patient we need to infuse blood very fastly. Okay, we need to infuse a lot of blood. That is why we are using gray or orange color cannula, right? So that is for the trauma patient. Okay, now let's talk about some important one liners. These two slides are left. Okay, so please try to answer, please try to answer whatever we have studied. We are going to discuss that. Okay, so which agent is not used in patient with egg allergy? Which agent cannot be used in patient with egg allergy? Your answer would be propofol. Guys, remember we have discussed propofol. Propofol means, propofol will be having what? It will be having EGS, that is egg, glycerol, and soybean, right? So we cannot use. Should not be used if open for more than 6 hours. Again, your answer will be again propofol. Propofol. Okay, very good, Muskan. So again, your answer would be propofol. Most common used in daycare surgery. Sir, why you are asking about propofol again and again? Okay, now try to answer. Which causes adrenal suppression that we have seen? Which of the following causes adrenal suppression? Try to answer, guys. Not propanolol, guys. Not propanolol. It is propofol, not propanolol. Okay, propanolol is a beta blocker. Okay, cardiac adrenal suppression. Yes, that is etomidate. That is your etomidate. Okay, most cardiostable IV agent that we are using in IV, we are having two classes: opioids, non-opioids. In non-opioids, we are having thiopentone, ketamine, propofol, etomidate. What would be your answer? Yes, that is etomidate. Okay, causes hallucination and delirium. Which one is causing hallucination and delirium? Yes, that would be ketamine, guys. That would be ketamine. Which one is most painful on IV injection? That is having all the that is basically propyl alcohol. That is basically a type of propofol. Propofol is a type of propyl alcohol. It will be having egg lecithin, soya all those things, right? So that would be most painful on injection. Best bronchodilator IV. Which drug is the best bronchodilator IV? Very good, Karishma Mihir. So best bronchodilator IV would be ketamine. Ketamine, guys, ketamine. Second gas effect or diffusion hypoxia, or third gas effect if you will be seeing along with the nitrous oxide N2. Okay, which one is preferred in children? Which one preferred in children? Induction in children, that is again your sevoflurane. 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 Okay, preferred for induction in asthma patient. In asthma patient, inhalational agent, which one will you use? Inhalational that you will be using is halothane followed by CO. Okay, preferred in induction in neurocardiac and liver surgeries, guys. Neurocardiac and liver surgeries, yes, we can use isoflurane. Okay, we can use isoflurane. Cardiac surgeries, preferred in induction in cardiac, renal, and liver surgeries, that would be your desflurane. Okay, we can use isoflurane, we can use desflurane. Okay, shortest acting depolarizing neuromuscular blocker, that would be your shortest acting would be your succinylcholine, guys. Succinylcholine, shortest acting would be your succinylcholine. Shortest acting non depolarizing neuromuscular blocker, I know, that is mevacurium. Mevacurium. Okay, fastest acting non depolarizing neuromuscular blocker, try to answer, guys. That is your rocuronium. That is your, just like a rocket, that is rocuronium. And the last one, Hoffman elimination, is seen with which thing? That is your atra and cis atra curium. Atra and cis atra curium. That's it, guys. I think we are done with most part of the anesthesia. Only one thing that is left, you have to study in emergency medicine, or you can watch other video that we are having. You can watch emergency medicine, and from that emergency medicine you need to study about BLS and ACLS. Apart from that, all other aspects I have already cleared. So I think that would be a useful session for all of you. Please do revise once more before the examination, and it's been only 25 days for your examination, so please try to give your 100%, and don't look for other things like internship, NMC. Just let it be. You can see all those things even after examination, nothing will change. They will delay it, they will delay the decision. So after exam you will be having a good time for that interesting topics. Okay, right now just focus on your examination, and this is my Instagram, this is my Telegram. Do let me know if you are having any doubts. You can always connect with me for positive feedbacks or some kind of suggestions, right? And any kind of doubts you are having, you can always ask me, right? So this is what we have done. Let me just recap everything for you, and then if you are having any doubts, you can ask me, right? So what we have done, we have done the introduction, we have seen the history part, then we have seen different types of anesthesias that we are having, then we have seen the pre-anesthetic checkup, that the patient is coming to us, what are the NP orders, what are the different things that we are doing. Then we have done the intubation to the patient, left hand में laryngoscope लेना है, monitors कौन से है, what are the different things that are present over there. Then we have seen the anesthesia machine. We are having three parts: high pressure, intermediate, low pressure. High में याद रखना है pin index. Apart from that, you need to remember the color coding of the cylinder. Intermediate, dis, you have to remember. Low pressure system, color of the vaporizers. Okay, most important. Anesthesia circuit, we have seen A, B, C, D, E, F. That is the semi circuit that you have to remember. A is for spontaneous. B, C, do not remember. C and D, sorry, D will be for control ventilation. E, do not remember. Just F is the Jackson Rees, pediatric or adult. Pediatric में controlled or spontaneous दोनों में circuit of choice. Okay, next we have seen the oxygen therapy. What are the different type of oxygen therapy we are having. Next we have seen the different kind of fluid we are using, and miscellaneous topics. Okay, all right guys, so dasvidanya, bye bye, bye bye, take care, have a good night, and do revise and do study subjects. We will be meeting for further sessions. We are having multiple sessions together, approximately 5-6 subjects I would be covering. From on 13 we will be having microbiology session, so please do join, and we will be having a good discussion over there. Okay, so good night. Yes, I will be sending the PDF. You can join Telegram. I would be sending the PDF also. Okay, thank you guys.